10th of the webinars in the series of 20 webinars funded by Global Genes for financial advocacy. And we are focusing on SMA and DMD. तो SMA और DMD के financial advocacy के लिए Global Genes की grant से ये हमारा series है. और आज के series में जो आज का फर्स्ट पैनल है, we will be talking about research में कैसे we can do in research in this area of neuromuscular disorders, especially SMA and DMD. And in the second panel, we will be having what are the government of India's the rare disease policy. So we have very esteemed speakers today, and I would request Dr. Kakuli to introduce the moderator, who is Dr. Satish Khadilkar, who's well known to everybody globally. Dr. Kakuli will formally introduce him and the panelists. Dr. Kakuli, and then we will give it over to Sir, you, and we'll put the questions on the screen, Sir. Kakuli.
Good morning, everyone. Thank you, Dr. Shefali, for giving me the handing over the dance to me. Welcome, everybody. Today we are on the 7th and 8th session of the webinar, series of webinars. The first session we will have is the need for research, ICMR and other government organizations. This session would be moderated by Dr. Satish Khadilkar. He is head of the Department of Neurology at Bombay Hospital and Medical Research. His skills and expertise includes DMD, peripheral neuropathy, and other neuromuscular and neurological diseases. He has many awards and publications to his credit. Let's welcome Dr. Khadilkar to moderate this session. The other panelists we have over here is Dr. Subrata Sinha. He is the head of Biochemistry Department and is Dean Research and also Dean Academics, AIIMS Delhi. Dr. Alok Bhattacharya is a professor at Ashoka University, and his previous assignments includes trained parapsychologist. He was an academician at JNU and is known to everybody for his research in bioinformatics and further. Dr. Anamika Gambhir is the program head of Women and Child Health DBT India. Dr. S.K. Rashni is the head international cooperation at DST India. Dr. Geeta Jotwani is senior deputy director, general scientist G ICMR India.
Recording on good. Dr. I.C. Verma.
And Dr. I.C. Verma is currently the head of genetic department at Sir Gangaram Hospital, New Delhi. Earlier, he joined AIIMS and established the genetics department in Department of Pediatrics, AIIMS Delhi. He has received many national and international awards. He is member and vice chairman of Ethics Committee of International Organization. He is also an advisor in genetics at WHO and Roche Genetics Switzerland. I welcome everybody, and now I request Dr. Satish Khadilkar to moderate the session.
Good morning. Good morning, everyone. And firstly, let me thank Dr. Shefali Gulati for arranging such a beautiful symposium on topic that is very, very relevant to us. And also, she's got together a real panel of experts who deal with these diseases day in and day out. So, Dr. Gulati, if I could ask you, our listeners will be partly non-medical or?
Yes, sir. So it is basically
largely
and parents. Yeah. So English में करना पड़ेगा.
Yeah. तो basically होता ऐसे है कि generally parents और patients जो होते हैं, वो जब डॉक्टर के पास आते हैं कोई बीमारी लेके कि जिसकी अच्छी दवाइयां नहीं है, तो फिर ये बातें आती है कि अभी दवाइयां नहीं है तो क्या कर सकते हैं, रिसर्च क्या होता है, कहाँ से वो चांसेस आएंगे हमारे लिए कि जब नई दवाइयां निकलेगी, ये सारे सवाल उनके मन में आते हैं. और आज की पोजीशन ये है अपनी कंट्री में कि काफी अच्छे लोग इसमें काम तो कर रहे हैं, लेकिन कौन कहाँ काम कर रहा है, क्या कर रहा है, इसकी इंफॉर्मेशन आम लोगों को होना थोड़ा मुश्किल अभी के समय है, क्योंकि छोटी छोटी जगह में अपना अपना काम लोग अच्छे से कर रहे हैं. तो अभी जो फोरम डॉक्टर गुलाटी ने इकट्ठा किया है, उसका मेन पर्पस ये है कि सबको जानकारी मिले, आइडिया आ जाए कि ये जो न्यूरोमस्कुलर बीमारियां हैं, जिनमें ट्रीटमेंट्स कुछ हद तक है, काफी हद तक अभी डेवलप हो रहे हैं, तो उसके लिए ग्लोबली क्या होता है और अपनी कंट्री में क्या होता है, उसमें पेरेंट्स और पेशेंट्स का भी क्या हिस्सा रहेगा रिसर्चर के साथ, क्योंकि ये साथ में मिलकर करने वाली बात है। तो व्हाट वी विल डू, we will keep the thing open to all the panelists, and I'll throw up a question, and whoever feels like taking it, please do go ahead and just say what you want to say about it, and then we'll generate a lively discussion about it. So first question is this: what is the current unmet research need for rare diseases, and why do we need research in rare diseases? पहला सवाल ये उठाया है कि रेयर डिसीज होता क्या है और उसके लिए रिसर्च की जरूरत क्या होती है, और रिसर्च अपने यहाँ किस कहाँ एरियाज है जहां अभी प्रॉब्लम्स है रिसर्च करने में। तो ये पहला सवाल है। मे बी इफ आई कैन स्टार्ट ऑफ विद अ लिटिल इंट्रोडक्शन। रेयर बीमारियां वो होती है जो आमतौर पे दिखती नहीं है और जिसके पेशेंट्स बहुत कम होते हैं। अपनी कंट्री में पॉपुलेशन इतना बड़ा है कि काफी सारी बीमारियां कॉमन तौर पे जो दिखती है वो हजारों की संख्या में दिखती है, लाखों की संख्या में दिखती है। लेकिन रेयर डिसीज जो है वो कई लाखों में एक व्यक्ति को होते हैं। तो ऐसे पेशेंट्स या तो मेडिकल नजारिए में आते नहीं है, या तो कई डिस्ट्रिक्ट प्लेस में या छोटी जगह में पहुंच जाते हैं तो आगे नहीं जा सकते हैं। तो ये एक तरीके से वो खुद को ऑर्फन के जैसा महसूस करते हैं कि भाई हमको बीमारी तो है, ना तो हमारे डॉक्टर्स अच्छी तरह से जानते हैं, ना तो इसका कोई ऑर्गेनाइजेशन है जहां हम जा सकते हैं। तो आमतौर पे इंडिया जैसी कंट्री में जहां अभी तक एजुकेशन की इश्यूज है, रूरल सेटिंग्स है, रेयर डिसीज की ये प्रॉब्लम्स है। तो कैन वी start with the answers? Whoever wants to start off, what is the current unmet research need for rare diseases? Who wants to start? Dr. Alok or Dr. Jotwani? Whoever wants to take it. I think let's keep the panel open. Yeah.
Maybe Geeta can answer it. I'll talk later.
Okay.
Okay, thank you. Thank you, Dr. Khadilkar, and I'm happy to join this panel discussion. It's very interesting to have you all around. Yeah, so what is rare, as you rightly said, which is not yet identified? I must say that it is rare in international scenario, may not be rare for India. So what I understand, there are quite I mean, whatever numbers the yardstick has been decided by international forums is not applicable to India. But here, rare in another definition is that there is no diagnosis, there is no set identification of the disease. We are all learning through. There are no treatment available for such diseases. There is we don't know what is the regime one should use for such diseases. So it's kind of a unidentified diseases, and there are many such genetic, some monogenic disorders. There are many other genetic diseases which are still internationally as well. We are trying to identify these diseases. So it's not that in India people are trying very hard. The doctors are trying hard. So it is important that each one of us to get together, to work together to identify these diseases. And we have to also set a capacity building in the area to help clinicians set up a network. If somebody is not able to identify, they can refer these cases to the other doctors and jointly help them in identifying these diseases. That's what, in very brief, I would like to say. Maybe we'll continue our discussions. Over to you, Dr. Alok.
Yeah, I think before Dr. Alok begins, I'll just make I'll pick up one point from what you mentioned. That diagnosis is often very difficult to make, and I mean we have a tier system with primary health centers and everything, But when such a doctor who is in a primary health center is going to see a rare disease, obviously there are going to be issues about reaching the diagnosis. And so in the modern times, with everyone having a cell phone and everyone having some kind of connectivity, how do you think one could sort of look at uh, a doctor who realizes that, okay, there is a problem here, but I don't know what the problem is, to reach that problem to somebody who may know, and then sort of take it from then. I think you touched upon a very important point. The first step is diagnosis. And how does one sort of integrate the diagnostic abilities throughout the country? Alok, sorry, I just sort of butted in. Maybe you sort of tell what you want to say, and then we come back to this point.
No, let Geeta answer that question.
Yeah.
So, sir, you rightly said. My first point was how to diagnose these rare disorders, and in periphery, maybe in a setting like AIIMS and PGI and many premier institutes, it may be possible when you are discussing it in an interdisciplinary way. You can contact the geneticist. Pediatrician can very well have dialogue with the geneticist and geneticist, and even other ancillary divisions where you can very well discuss this, have a conference and do that. These days, as you said, internet, each person has a phone in his hand and people are connected through WhatsApp, through social media, everything. So similarly, doctors are also very connected. So they can consult the senior doctor, a doctor like you, or we can have those forums where weekly conferences should happen, and they can discuss undiagnosed cases there. So you can make a detailed clinical observation and share with your through the societies, forums, and such a webinars. We can discuss such diseases through telemedicine, which is the best tool, I think, today's time. So in the remotest area, doctors can connect it to the premier institute doctors, and then they can have conference and decide that what they are finding are is anybody can help them in diagnose that, and after diagnose, then they can be further taken up for the proper channel to treat these diseases.
Correct. Fantastic point. I mean, we must have a system whereby they can interact and create a website or a forum which is well known to everyone. Yeah. Dr. Alok, can we come to you?
मैं तो सहमत हूँ बिल्कुल डॉक्टर गीता ने जो बोला, डॉक्टर खादिलकर ने जो बोला है कि हम कैसे डायग्नोस कर सकते हैं. मेरा तो आइडिया कुछ और था कि फॉर एग्जांपल कैसे हम स्क्रीन भी कर सकते हैं. जैसे फुट ड्रॉप तो वन ऑफ द अर्ली साइंस ऑफ न्यूरोमस्कुलर डिसऑर्डर में होता है. तो we can do gait analysis. आजकल टेक्नोलॉजी जितना है, मोबाइल फोन से वीडियो लेके आप भेज दो उसको, AI बेस्ड टूल से एनालाइज हो जाएगा, and then something can come up from there. I mean, something we have to हमें सोचना पड़ेगा out of box to come out with a possibility. Whole, if you can screen school children, college kids for a adult onset disease and then try to see, you know, जब तक हम penetrate नहीं करेंगे lower level पे, you know, remote level, we कभी हमें मिलेगा नहीं all the diseases. Second thing मैं जो बोलने वाला हूँ, which is very very important, कि rare disease के बारे में ना हमारे ज़्यादातर डॉक्टरों में जानकारी है, neither हमारे साइंटिस्ट में जानकारी है, and in fact गीता, sorry to say, neither हमारे एजेंसी के साइंटिस्ट में जो फंडिंग करते हैं उनको जानकारी है. उनमें आप जैसे लोग हैं, बहुत रेयर हैं जो इसमें हैं, ये भी रेयर है, बट मैंने देखा है कि the importance of working on rare disease and finding drugs, ये तो हमें एजेंसी के साइंटिस्ट को भी सिखाना पड़ेगा, because उनको भी generally they don't understand the importance of the whole thing. तो हमारे सबसे बड़ी जो प्रॉब्लम है लोगों में, all stakeholders, government, agencies, doctors and scientists, सब में जानकारी होनी चाहिए. Even industry, I mean, one or two that I have approached, there are some who are very, very positive, मैंने Genova से recently I've talked to them very much. उनके जो head हैं, he says I'll do anything to help rare diseases. There are very few such industries that are there. They just say, oh, आपके तो 10 patient हैं. Somebody said, he said मेरे WhatsApp group में 200 patient हैं. Don't say 10 patient. Okay. I mean, so first thing is that information इस डिजीजों के बारे में सबको बताना चाहिए. कैसे करें? That's a big challenge to do. मैंने साइंटिस्ट से बात करता हूँ, वंस आप एक्सप्लेन करो कि ये सिचुएशन है, ड्रग्स नहीं है, आप लोग कुछ करो उसके बारे में. हम बायोलॉजी भी नहीं जानते हैं इनके बारे में. देन दे गेट इंटरेस्टेड, बट बिफोर दैट दे आर नॉट इंटरेस्टेड. दे डोंट इवन नो क्या होता है. तो मैं पहले बोलूंगा कि कुछ करने जाओ उसके पहले आई थिंक somehow or other we have to plan the way we can educate everybody, all stakeholders on that. Second thing, I just say that, and मैं बोलता आ रहा हूँ, some of you already know that, जब तक हम इंडिया में ड्रग्स नहीं बनाएंगे, we cannot handle this patient. जितना भी पॉलिसी बने, जो कुछ भी बने, सेंटर ऑफ एक्सीलेंस बने, बट जब तक हमारे देश में ड्रग्स नहीं बनेगा और हम नहीं बनाएंगे, हमारे पेशेंट्स को एटलीस्ट नॉट ऑल पेशेंट्स विल गेट फ्री. और हमें whatever करना चाहिए, whatever helps to for us to actually make this drugs and
Right.
ये मेरे points are.
Right. Thank you. Dr. Varshni has to go early, so can we listen to his thoughts now?
Thank you very much, sir. I am on the other side actually, what Dr. Alok just mentioned about education to the scientists working in various agencies. So my Department of Science and Technology, we are promoting all kind of sciences, including medical sciences, including biomedical sciences, biosciences, besides other sciences. So we, along with ICMR and DBT, play a critical role in promoting medical research. And I am responsible in the Department for International Scientific Cooperation. And idea is that wherever we could provide linkages to overseas communities. So we have done supported research based on genes, like comparing European genes with Indian genes and vice versa, on various diseases, various Prakriti models, what we are doing. And we are also supporting, we have a program called IRFA. I'm not sure how many of you are familiar with the DST, because you might be familiar with a lot of ICMR DBT programs. But IRFA is a program we call intense research in priority area, high priority area. So for example, for last 2 years, it was COVID. It could be anything, depending upon what kind of research we are promoting. So we have our regular channels where we are doing it, but we would love to know more and more medical challenges to our community. And we would also love to see what are the options available to us as far as best practices of that particular disease treatment protocols are available across the world. And we could connect our medical community to that group. So I would like to assure you that we have program with nearly 80 countries around the world. And these include our cooperation program with developed countries, developing countries, and least developing countries. So we are working in Africa, we are working in Asia, we are working in Europe, America, Australia, everywhere we are working. And we would like to, of course, first is our own community. What are the diseases our community is facing, which could be because of agroclimatic zones, which could be waterborne, which could be depending upon our food. And then if we could solve problem of some of the poor countries, then we would like to ask our medical community to help them also. Thank you very much. I'm here for another 20 minutes, sir. So
Yes.
I will
Yes.
continue.
Yeah, thank you. Thank you very much. It's very nice to know that agencies like yours are there to try and help people. Can I just ask you one question? Since you are on that side of the table, generally when you receive projects and receive things from medical doctors or otherwise, do you have any some maybe doctors in our audience? So do you have any general comments or suggestions to make for them as to how they should go about? Because when in small organizations, small hospitals, small institutions, when somebody wants to put up a project, he's also thinking small, I think. And thinking small doesn't go a long way. So what's your advice?
One of the things any researchers should keep in mind while conceiving a research proposal, that what is the kind of novelty, scientific novelty he or she is bringing in, and what is the kind of value addition the fellow is proposing over existing knowledge. If one could establish one of these two things, then it is easier for our referees to support such ideas. And if you have got a particular challenge in mind which you are trying to solve, that makes referees much more comfortable in reading your proposal and going through. And I'm very sure that they go and see your background, what kind of work you have done, and if your previous experience could be useful in answering the new challenge which you have adopted, we would love to support these projects. And since you have asked this question, I would like to say that we are supporting those fellows who have just completed PhD and are unemployed, who are young faculty below 40 years of age, and then we are having regular program for anyone to participate. So we are calling those unemployed fellow as postdoctoral program of DST, and then for young faculty, startup research grant, and for anybody we have got core research grants. But scientific novelty, purpose of research should be very, very clear why you are doing this thing. And if, because medical community is always connected to the society, so if you are answering this challenge, we would more than welcome you. Thank you.
Thank you. Thank you. So I think for everyone who is listening, he's made a very important point that basically these organizations fund areas where new contribution happens. And if that new contribution is directly helping society, nothing like it. So I think when those of you who plan, you plan, please look at it this way. Can we sort of take comments from Dr. Gayatri, Dr. Farooq, Dr. Gambhir about diagnosis and about role of various agencies, the 2 points that we have covered up till now, before we move on?
Yeah, can I come in then?
Please, Dr. Gayatri.
Yeah. So we have been involved in diagnosing neuromuscular disorders for the past more than 4 decades, I could say. So muscle biopsy does play a very important role in the diagnosis. It's not just the biopsy and the ancillary tests that we have. Now we have a lot of additional investigative procedures that are there, and then all of these have to be adopted to give in a definitive diagnosis. Now, despite all of this, we ourselves, it is our own experience to tell that more than half, rather the 50% of the cases go undiagnosed. Now, what is the cause for this? So we still do not know what the cause for this is, because whether we have taken the biopsy very early in the stage of the disease, or it is not reflected in the muscle that we have taken. So there are a lot of challenges even here during the diagnosis of muscle disorders. Now, one of them we did face was to differentiate between a Duchenne muscular dystrophy and
the other autosomal recessive muscular dystrophy. Now, histopathology, if you say, of course, all of these are the rare disorders. Histopathology across all muscular dystrophy will be identical. Now, to differentiate between them, you need to have additional tests. Now, how many of the centers will have these additional tests that you can offer to give the diagnosis? The other thing is, when people talk about rare disorders, it's just the Duchenne muscular dystrophy and spinal muscular atrophy. Now, it doesn't stop there. There are several others. For example, the congenital myopathies. Now, recently I had a phone call about some of the patients who have been diagnosed as mammalian rod myopathy. Now, how often do doctors see mammalian rod myopathy, and they come with acute respiratory involvement? Now, how do you deal with such cases? Now, so you just can't say it's just muscular dystrophy and SMA, but there are several others, including the metabolic disorders, and mitochondrial disorders is another huge condition where you cannot offer the diagnosis even on the muscle biopsy. Again, in mitochondrial disorders, we have only a subset of the mitochondrial disorders where the pathology can be seen on the muscle biopsy, while in the rest it is not. So we thought, okay, we need to have additional tests, and then we now have started the respiratory chain assays for these disorders. Now, even after applying all these ancillary tests, we still cannot diagnose 100% all of these cases. So muscle biopsy, of course, it does play an important role, but then how far can you offer the diagnosis? And the diagnosis is most important. So
Right.
we also, yeah.
Hanani, please.
So we also found that while we took up the genetic analysis of some of these subset of disorders, and then genetics also does not give us the answer, because you have either novel mutations or a particular case will have more than 3 or 4 mutations. Now, where do we go? And you go back and see the muscle biopsy, it's just a muscular dystrophy. Now, where do we stand? So there are a lot of issues that we need to address with respect to not just the pathology, but the other things also in muscular dystrophy. So in the recent past, there are the omics which have come up, the proteomics, the metabolomics, etc. Now, are we going to adopt all these and then give a panel for the diagnosis of these disorders? Is $1 million questions, because for a patient to come, ours being NIMHANS being a tertiary referral center, many of them, they come for muscle biopsy. The muscle biopsy is done, but then when we say, no, these are the additional tests that needs to be done to give in the diagnosis, unless they are the BPL patients wherein we can offer them free of cost, the other patients who are the paying patients, they refuse to get these tests done, because they say that, okay, if you give me the answer or a proper diagnosis using the other tests, will there be cure for my child? Now, whether I should spend money for getting a diagnosis like that, or should I spend money buying a wheelchair or medications or whatever other physiotherapy that needs to be done for the patients? Now, there are a lot of these issues that needs to be addressed also.
आई थिंक सारे सुनने वालों के लिए डॉक्टर गायत्री ने जो मेंशन किया कि डायग्नोसिस में कई हिस्से होते हैं, जैसे डॉक्टर एग्जामिन करता है, फिर टेस्ट किए जाते हैं, उसमें उन्होंने एक मसल बायोप्सी नाम की टेस्ट का जिक्र किया जो कम जगह में होती है, उसमें अपनी मुश्किलें भी है डायग्नोसिस करने में, और फिर उन्होंने जेनेटिक्स का भी जिक्र किया, और ये सारी चीजें साथ में लेके डायग्नोसिस बनती है. तो डायग्नोसिस के कई छोटे छोटे हिस्से हैं. I think Dr. Jotwani wants to say something. I see the hand. Yeah. Dr. Jotwani, you want to say?
Thank you. Yeah. So I'm happy the way we are moving. I mean, what Dr. Gayatri also mentioned, the diagnosis, it's a multi-pronged approach we need to take to diagnose certain cases. And of course, the affordability of these available tools in the country. Rather, they have made it very exorbitant priced. But I think as the number goes up and the competition goes up, probably the value of the charges for these diagnoses will come down. That's what we understand. And I think there are many centers which are offering genomic analysis and all. Actually, the right information and right for the information is both the very different part of it. So right information means the education and awareness, which Dr. Alok very rightly said. So it's not only the doctors or the patient groups, it's each stakeholder participating in these kind of different part, aspects of providing these services. I think all the stakeholders needs to be educated. They should be aware of what is what. And of course, the protocols for these diseases, we need to have a proper diagnosis, SOPs, that step by step, how the doctor should move on in diagnosis of these rare disorders, not only rare, any kind of, I think. And there should be like the standard treating protocols there, STWs, which ICMR is already working on. But of course, for the rare diseases also with the knowledge available in a public domain or scientific knowledge available, we need to define such protocols for disease diagnosis and of course the treatment and the management of that disease. And another thing, the right information for all the patient group, what is available where, what is the cost of it, how they should proceed about it. And these are very important, and which we, ICMR has always kept in a multi-pronged approach to provide this information through FAQs on ICMR website. So I think we all can join hands and develop these kinds of SOPs, protocols, and also the frequently asked question. So we time to time invite the groups of the experts to help us in answering these questions. So just whatever discussion has been there so far, I thought I should give my inputs there. And then another, Dr. Alok also raised a question of indigenous drug development. Definitely, India is a vaccine giant. We provide 67% of vaccine all over world. We are generic, again, the generic drugs are developed in India. So why can't we develop these drugs in India? So of course, we can work together. So there has to be we need to come together. Dr. Vashni also said that all the agencies, if they work together, and the networking of the doctors and the people who want to work towards the drug development of this rare diseases, I think we need to work together and see how we can have affordable drugs made in India by setting up groups who think about how we should move and how we should direct indigenous drug development and make it affordable for Indian patients. Thank you.
Thank you. Thank you. I think Dr. Varshni has to leave shortly. So, sir, do you want to give any message to people before you?
Yeah, I would like to endorse what just now Dr. Geeta said. Affordability is one of the key aspects, be it treatment or drug development. And even while, if I could say, diagnosing the disease, because in our country, there are several areas which are inaccessible, hilly, or covered with difficult terrains. People have to go a long distance even to get diagnosed. Treatment is, of course, very, very expensive thing. And I always tell that India is home to 5-star hospitals. We attract a lot of medical tourism. But for our own people, for our common masses, we are still struggling. And if we could develop solutions which are affordable in nature by our society, then that goes a long way. And I look forward for any suggestions. And of course, I would also like to endorse Geeta's view and we are working for a tomorrow where project submissions could be on a single platform for all scientific agencies. So as a researcher, you are not confused if you should go to DBT or you should go to ICMR or you should go to DST or some other agencies. So just now, like we are having our bank ATM cards. So earlier you could encash it only with that particular bank credit card machine. Subsequently, there was a cartel of bankers who could come together, and today you could encash your ATM card from any of the bank machines. So we would like to develop a portal where anybody could submit proposal, and depending upon the project interest, it could be agency could be assigned, and each agency would be knowing what kind of work you have been supported by other agencies. So single platform is a key priority of the government, and we are working on that. Thank you.
It's terrific knowledge. Thank you very much for sharing it with all of us. And a lot of researchers who hesitate in early in their careers will find this useful. Thank you. Dr. Shefali, you wanted to say something?
Yes, sir. Sir, before I wanted to say that Dr. Subrata Sinha, our Dean Academic and Dean Research is here. I'll request him to make comments because he has to leave. But before that, one thing before Dr. Varshini leaves. Sir, I just felt that if we are having, is he there? Dr. Varshini, are there?
Yeah,
still?
he's there. Yes.
Yeah, I'm here.
Yeah, no, actually, sir, I feel when we get proposals on one particular thing, they don't have, they are thinking on the same process. They'll have so many. If you go and see, when you're going as a reviewer, you will have some all on genomics or something. They will do proteomics. Can't we have all of them together, brainstorm and make a consolidated proposal, and so that we get a logical conclusion to this I felt, and what Dr. Gayatri was saying, that everything is not SM and DMD. Ma'am, in the first two webinars, we talked about all the spectrum, and because this is a financial advocacy grant from Global Genes, so that's why we're focusing on the two of the commonest rare disease for which we have it available. And other thing is, like you're talking about muscle biopsy, we've done some studies in which we're trying to see whether a muscle biopsy can replace a skin biopsy can replace muscle biopsy. That because of the erector pylori staining and all, because that will be that may help. We've had some papers that may help in these drug trial, the intervention trials now, because the parents will not allow repeated muscle biopsy. कोई parent allow नहीं करेगा, skin biopsy allow करेंगे. And sir, ये जो सारे के सारे जो we have all these webinars are there live streamed on YouTube as well, and will be on our AIIMS website, Child Neurology website, and Global Genes website. With your permission, can I ask Professor Subroto Sinha to make his comments, sir?
Please, please, please. Dr. Sinha, thank you very much for joining us, and we're looking forward to your comments.
Good morning, and I am really pleased that this webinar symposium is being conducted on an issue which has recently come into public spotlight, even though it wasn't really so obvious before. But the point is that we are all looking for, solutions, and in the process of looking for solutions, I can only, some of it I would be repeating what Dr. Geeta, Dr. Vashne, and others have been saying, but in a way, I'm endorsing what they are saying. On one hand, we are looking at a level of basic access where a person should have access to basic healthcare, basic rehabilitation, basic support measures. So that is one end of the spectrum. And for most of the Indians in India, that is the reality. Things stop there. It is very difficult to, especially with a, typical averagely financed family, let alone a poor family, to go any further with it. So on one direction is access. On the other end are these very tantalizing heights of science. These tantalizing heights of science are telling us that, look, what we had thought was incurable is not incurable anymore. But so therefore we need proper diagnostics, proper molecular diagnostics, and then accessibility of therapy. And then, of course, we all know that there are these figures in crores which astound us, which I don't even think that the top 1% of the taxpayer bracket in India could ever achieve. So we have kind of three objectives in a way. One is increasing access to a basal facility and raising the standard of that basal facility higher and higher. Even a 10%, 20% incremental rise in that basal facility would do a world of good, provided it stretches across the entire population. So that is one aspect. The other aspect is that can we adapt, as everyone said, can we not adapt those therapies which are there uh, in a way very similar to, let us say, a biosimilar like model, and try to adapt them to India? Because from what I gather, where I have been associated with ICMR and Geeta in their gene therapy task forces and all that, and my basic assessment of it is that the technology is not really that mind boggling, especially, oligonucleotide based therapies are something which I feel are very amenable to our chemical engineering expertise. And even our gene therapy, at least our basal levels of expertise are pretty good. They just need to be expanded and sort of carried forward. So that is one end of the spectrum. The other end of the spectrum is to carry out research on how the uniqueness of the Indian population to known disorders, to try to find out unknown disorders, and to then find out novel therapy. So these are the three ends of the spectrum. Now, to me, one of them, of course, is a major public health issue which needs to be tackled at the access part of it, at the level of, let us say, informed knowledge to the governmental agencies could be provided, which would really tell them how to focus their efforts in order to dovetail these specific requirements into the needs of such people, people who require it. Then the other issue remains is the biosimilar model. People talk about the vaccine model, and and I really appreciate this is a source of pride to us. I think we all have to do that. But let us understand the vaccine model actually comes from a business model which is essentially linked to huge amount of government procurement and WHO procurement. So it is not a typical retail procurement in the. It is there. I'm not saying, but for most of our, at least, which are part of our vaccination and immunization program. So the essentially the monetary driving force driving that model, and then first of all we started with simpler vaccines and more complex vaccines and more regulations, and now with newer COVID vaccines. So this is a kind of impetus. So somewhere a kind of an impetus of that nature, because without it, either you have a national policy where you reinvent structures like your IDPLs, Indian Drugs and Pharmaceuticals, and decide on a state policy, or within the private sector, what do you do to incentivize or to at least, let us say, reduce the financial uncertainty of these high cost, high input, and rather uncertain enterprises. So, of course, this will come only for drugs which are of and known therapies, and in a way partly can be replicated for molecular diagnostics as well. So these so this is something that we need to, because unless we have a kind of a because I do feel that this is something which is likely to hamper our progress in delivery. And finally, there's a kind of a, it's not a good thing to say, about trickle down effect, that if the high end gets more and more competitive and cheaper, as has been said before, then accessibility increases. So these are models for development, and I really appreciate the single platform with a slide for submitting research projects, which is true. But uh, you know, every let us say that we have a heterogeneity of thought when we are doing at least basic research as opposed to translational research. And within that, there are different agencies with different characteristics, which is also very useful for promoting the heterogeneity of thought. So the heterogeneity of thought should also be maintained in our single platform submission. So with this, thank you very much. And I really hope there'll be a new input and a new direction to this work. Thank you.
Thank you very much, sir. Thank you so much for your comments. Kadilkar sir, Dr. Kakuli missed introducing Dr. Farooq, who has to leave. So they should just introduce Dr. Farooq, and Dr. Farooq, can you will seek his comments before he leaves. He's taking somebody's interview.
Yes,
Dr.
please.
Farooq is a senior scientist at CSIR IGIB, Delhi. His main interests are molecular biology, genetics, and neurosciences. Dr. Farooq.
And he's our collaborator for all these neuromuscular diseases.
मैं धन्यवाद देना चाहता हूँ डॉक्टर शिवालिका एंड प्रोफेसर सतीश एंड ऑल अदर पैनलिस्ट। मैं ये कहना चाहता हूँ कि हमारा संस्थान ऑलमोस्ट लाइक पिछले 20 सालों से इस एरिया से जुड़ा हुआ है, genomics and genetics, and we are into diagnostics, basically helping not only patient with the diagnosis but also हमने बहुत सारा रिसर्च भी किया है। एंड हमारा जो डिसऑर्डर जिस पे हमने शुरुआत से काम किया है, बहुत भांति भांति प्रकार के डिसऑर्डर्स, जेनेटिक और रेयर डिजीजेस पे हम काम करते हैं। और मैं चूंकि बात अभी ये अनमेट नीड की हो रही है, तो आवश्यक जरूरत है इस एरिया में। तो एक तरफ हम बात करते हैं इलाज की, तो इलाज तो है ही, उसके अलावा डायग्नोसिस की काफी जरूरत है। तो मैं समझता हूँ कि इसकी तरफ जो हमारा प्रयास है वो इस तरफ होना चाहिए कि इक्विटेबल एक्सेस हम प्रोवाइड करा सके, जहाँ पे कोई भी मरीज जो कि इन बीमारियों से ग्रसित है उनको कोई भी जांच के अभाव में ना रहे, और ताकि हम ज्यादा से ज्यादा उनको वी कैन कैच देम अर्ली, और ताकि हमें ये पता चले, हम पॉलिसी मेकिंग कमिटीज के पास जाते हैं तो उनसे हम अच्छी तरीके से बता पाए कि हमारे यहाँ पे डिजीज का बर्डन कितना है। एज भी से कि हम हमारे यहाँ पे लाइक पूरे वर्ल्ड में अभी तक 7,000 रेयर बीमारियां पता है, लेकिन एक बात ये कहना चाहूंगा कि सारी बीमारियां एक जैसी समान कॉमन नहीं है। कुछ रेयर है, कुछ बहुत रेयर है, कुछ अल्ट्रा रेयर है। सो मैं समझता हूँ कि शायद 80% जो रेयर बीमारियां है, 80% जो मरीज है रेयर बीमारियों के, वो करीब 150 या 200 प्रकार के जेनेटिक डिफेक्ट से जुड़े हुए हैं। तो मुझे लगता है कि अगर हम सारे की सारे जेनेटिक बीमारियों को अगर हम नहीं टच अपॉन कर सकते, मे बी फॉर द कॉस्ट पर्पज, और हमारे पॉपुलेशन का साइज ज्यादा है, तो हमें लगता है कि एटलीस्ट हमें फंडिंग एजेंसी, इवन आईसीएमआर, डीएसटी और दूसरे जो संस्थान है उनको आगे आना चाहिए, ताकि रिसर्च के अलावा एक वो सर्विस के माध्यम से भी रिसर्च को प्रमोट कर सकते हैं। उनको उन प्रोग्राम्स को भी फंड की तरफ ले जाना चाहिए, फंडिंग की तरफ ले जाना चाहिए, जहां से हमें सर्विस दे सके, सोसाइटल वर्क कर सके। ताकि अभी जो डॉक्टर आलोक ने भी बताया कि जागरूकता का अभाव है डॉक्टर्स में, साइंटिस्ट में, तो अगर हम कॉमन बीमारियों को जो हमारे इर्द गिर्द रहती है अक्सर, अगर हम उसकी तरफ ध्यान देंगे तो अपने आप ही मुझे लगता है कि जागरूकता बढ़ेगी। और मुझे लगता है कि जैसा हम इस प्रोग्राम से जुड़े हुए हैं, और हमारा एक प्रोग्राम है जो कि जिसका नाम है इक्विटेबल एक्सेस टू जीनोमिक मेडिसिन, उसके तहत हम करीब 400 बीमारियों का सिंगल जीन द्वारा हम जांच प्रदान करते हैं। और सिर्फ हम जांच प्रदान करने तक ही सीमित नहीं रखते अपने आप को, हम कोहॉर्ट बिल्ड करते हैं, जिससे कि हम ज्यादा से ज्यादा और रिसर्च प्रदान कर सके हमारे देश के लिए। और मुझे लगता है एक कॉमन लास्ट पॉइंट मैं बोलना चाहता हूँ कि ये वो एरिया है जेनेटिक्स एंड जीनोमिक्स, हमारे पॉपुलेशन साइज को देखते हुए, रेयर डिजीज के प्रिवेलेंस को देखते हुए, जहाँ पे हम वर्ल्ड में लीड कर सकते हैं। और ये सही वक्त है इस तरह के फोरम में बात करना, और हम लोगों को एकजुट होकर अगर हम आगे चले, तो मैं समझता हूँ कि आने वाले मतलब डाउन द लेन 5 साल बाद हम इस फील्ड में लीडर हो सकते हैं। और यही मैं बात कहना चाहता हूँ। धन्यवाद।
Thank you very much, sir. From the panel, does anyone want to ask any questions to Dr. Farooq or clarify something? He's made some very important points. As he has to go early,
I would like to, I'm very happy what he said. And I would like to add to this कि हमारे देश में बहुत सारे गवर्नमेंट संस्थान हैं जहाँ इस तरीके की फैसिलिटी, डायग्नोस्टिक फैसिलिटीज अवेलेबल हैं। डेफिनेटली ये सबके लिए एक्सेसिबल नहीं हो सकता, देश भी बहुत बड़ा है, पॉपुलेशन भी बहुत ह्यूज है। So काफी challenges government agencies and even ministry, health ministry की तरफ भी काफी challenges हैं to make it accessible and available for. I'm affordability में अब secondary रख रही हूँ. पहली बात है accessible and available. And ये प्राइवेट एस्टेब्लिशमेंट में भी है, जैसे आईजीआईबी ने काफी इसमें एक्सेल किया है एंड दे आई थिंक डॉक्टर फारूक, मुझे लगता है कि ये इंफॉर्मेशन हमारी वेबसाइट्स पे आ जानी चाहिए इंस्टीट्यूट के कि कौन से डिजीजेस के लिए आप डायग्नोस्टिक जीनोमिक डायग्नोस्टिक्स के लिए आपके पास सर्विसेज हैं. एंड ऑफ कोर्स आईसीएमआर जैसी एजेंसीज हम कोशिश ही यही कर रहे हैं कि जो diagnostic services या any kind of services through our 33 institutes of ICMR which are working and specializing अलग-अलग disease के लिए specialized centers हैं ICMR के. So कई सारे genetic disorders जैसे hematological disorders के लिए मुंबई की संस्थान है हमारी National Institute of Immunohematology. उस तरीके के जैसे ट्यूबरकुलोसिस के लिए मैं जस्ट एक जनरल एग्जांपल दे रही हूँ कि ऐसे संस्थान हैं जो कि इस तरफ काम कर रही हैं और एक्सेसिबल सॉल्यूशंस एंड डायग्नोस्टिक्स के लिए और सर्विसेज के लिए तत्पर हैं. सो वैसे ही आईजीआईबी हैं, सीसीएमबी, सीडीएफडी, ऐसी बहुत सारे हैं इंस्टीट्यूशंस इन द कंट्री जिनके पास आईसीएमआर, डीएसटी, डीबीटी जैसे एजेंसीज ने उनको काफी मतलब इस तरीके से एस्टैब्लिश किया है और प्रमोट किया है ताकि वो सर्विसेज दे पाएं इन अ डिफरेंट रीजन्स ऑफ द कंट्री. सो एक और दूसरी बात मैं कहना चाहती हूँ कि नॉट ओनली वन टूल, वी हैव टू हैव अ मल्टी प्रोंग होलिस्टिक अप्रोच फॉर एनी डिजीज. जस्ट टेक अ एग्जांपल ऑफ एसएमए एंड डीएमडी. हमारे पास बहुत सारे पार्लियामेंट क्वेश्चन आते हैं, आरटीआई आते हैं, ग्रीवांसेस आते हैं पेशेंट से. उनको पता ही नहीं है कि हमारे बच्चे को डीएमडी हुआ है तो मेरा फर्स्ट काम क्या है, मुझे क्या ट्रीटमेंट मिल सकती है और ट्रीटमेंट कहाँ अवेलेबल है, कौन से किस तरीके का मतलब हाउ वी शुड गो अबाउट द ट्रीटमेंट फॉर डीएमडी और एसएमए. अब जीन थेरेपी जैसे सॉल्यूशंस तो अभी डेवलप हो रहे हैं, अभी तो अंडर डेवलपमेंट में हैं, बहुत सारे क्लिनिकल ट्रायल्स चल रहे हैं एंड अफोर्डेबल नहीं है, दे आर वेरी एक्सपेंसिव. एंड एज आई सेड, मैंने कहा कि यदि हम ये सॉल्यूशंस इंडिया में डेवलप कर सकते हैं तो हमारे सारे पेशेंट्स के लिए वो एक्सेसिबल होंगे. उसकी तरफ भी हमारी काफी कोशिश आईसीएमआर की चल रही है ताकि ये ड्रग, दिस काइंड ऑफ न्यू जनरेशन टेक्नोलॉजीज इंडिया में अवेलेबल हो सके और पेशेंट्स को इसके फ्रूट्स मिल सके. सो ये कोशिश चल रही है, रजिस्ट्री भी चल रही है. रेयर डिजीज, नॉट ओनली रेयर डिजीज, मेनी सच रजिस्ट्रीज व्हिच आईसीएमआर हैज अंडरटेकन फॉर डिफरेंट डिजीजेस. एंड अनमेट नीड की हम बात करते हैं तो आज बोन मैरो ट्रांसप्लांटेशन भी नहीं अवेलेबल है फॉर थैलेसेमिक्स एंड सिकल सेल डिजीज एंड बोन कैंसर जो है हेमाटोलॉजिकल कैंसर्स के लिए. सो देयर इज अ ह्यूज अनमेट नीड बिफोर द नेशन. एंड हमारी कई सारी हमने नेशनल लेवल कमिटीज भी बनाई हैं, द जीन थेरेपी एडवाइजरी एंड इवैल्यूएशन कमिटी जिसके चेयरमैन डॉक्टर सुब्रतो सिन्हा हैं. एंड बहुत सारे, इट्स अ ह्यूज मेंबर कमिटी, 33 मेंबर्स कमिटी जिसमें सारे एजेंसीज भी, गवर्नमेंट एजेंसीज भी पार्टिसिपेट करते हैं. जहां पेशेंट एडवोकेसी के लिए भी रूम है, वी हैव अ सेपरेट ग्रुप टू डिस्कस दिस कि हम किस तरीके से ग्रास रूट लेवल पे भी काम करें, इंक्लूडिंग awareness, education, easy solutions, a proper disease protocol, a treatment worksheet for a basic जो requirement है. जब किसी पेरेंट्स के पास एक डीएमडी मतलब बच्चा है तो वो किस डायरेक्शन में कैसे जाए, कहाँ से वो शुरू करें, किस तरीके की बेसिक ट्रीटमेंट, बेसिक हेल्थ केयर उनके लिए अवेलेबल हो, इस तरीके के क्वेश्चन फ्रेम करने के लिए वी आर हियर रेडी. And we would like to bring सब कुछ साथ में, even patient groups को, advocacy groups को, ताकि हम ये answers दे पाएं. क्योंकि मैंने खुद realize किया है कि हमारे टेबल पे रोज questions आते हैं कि ये क्या है. तो मुझे लगता है सभी clinicians, scientists and other agencies we can come together और साथ में काम करके हम एटलीस्ट उनको एक सही रास्ता दिखाएं ताकि वो मिसलीड ना हो। बहुत सारे ऐसी एंटिटीज भी हमारे कंट्री में हैं, वो उनको मिसलीड कर रहे हैं, उनको थेरेपी ऑफर कर रहे हैं। आज आपको हमें कुछ ही दिनों में मैं कहती हूँ आप देखेंगे कि लोग जीन थेरेपी ऑफर कर रहे हैं रोड साइड क्लिनिक में, जबकि पता ही नहीं लोगों को जीन थेरेपी बनती कैसी है। इट्स अ वेरी हाई एंड वेरी कॉम्प्लिकेटेड ड्रग्स आई मीन ट्रीटमेंट सॉल्यूशन। सो ये अवेयरनेस लाना हमारे तरफ से हमारी कोशिश है, और हम चाहते हैं कि हम वी शुड जॉइन हैंड्स, सब साथ में मिलके इसकी तरफ आगे कुछ करें और लोगों को सही राइट टू इंफॉर्मेशन एंड राइट फॉर राइट इंफॉर्मेशन वी शुड वर्क टुगेदर।
Very well said.
So can I make a
I think
point
it,
here?
yeah. I mean, I was going to invite who's speaking, please.
This is Anamika.
Hi, actually, I was going to invite you and then Dr. Arun Shastri to make your comments. And if I could give one question, you want to make a comment on what has happened? Then yes,
comment on what Dr. Farooq just said and what Dr.
Yes,
Chikita
yes,
about availability of diagnostic facilities for the patient. So I just wanted to inform that DBT has also launched. DBT has joined hands and wants to be a significant contributor, to the implementation of the national policy for rare diseases. And in this effort, an Umeed initiative has been launched, wherein we have established genetic diagnostic units across the country. 15 are already there, functional, and another 45 are there in the pipeline. And we are going to expand this network even further. But for those rare diseases, obviously, there'll just be a couple of centers which would be authorized to give the correct diagnosis, because not everybody can do that. And this facility is also going to counsel the parents about their future children. We have seen that a family with one child with TMD, when they go into the diagnostic centers, a couple of them high-end, high on money component centers, and they offer them diagnostic tests. Many a time when they clear them out that, okay, the second child, the amniocentesis sample is clear, again, the child has DMD, right? So these problems we are very well cognizant of, and we are trying to see that there should be just one center which can be state of the art, and wherein, if that center says that this child is not going to have, the particular genetic disease, that should be a clear cut, yes, and should be the go-to for those parents, right? So that is one thing that I wanted to tell, because this was in continuation to what Dr. Farooq said, that a service component should be there. Although we are a technology development department, we did think that this was important, and therefore this kind of service is also being given from DBT. So as part of the research components, there are we have clear-cut priority areas for the rare genetic diseases, and which include not only providing the mechanistic insights, including genetics, pathobiology, but also looking for newer therapeutics. So with AI becoming available, development of new computational methods for predicting, the effects of mutations in different genomic backgrounds vis-a-vis rare diseases. Then repurposing of drugs is another important mandate of our department. Repurposing of drugs towards development of novel therapeutics. And I would like to give one example where, from BIREC, we have given out a safety and efficacy trial to an industry for 2-O-methyl phosphothionate, which is an antisense oligonucleotide. Dr. Shubhrat mentioned that oligonucleotides could be a possible solution. And this is just a safety trial. And I think the first trial in India. It is being tested outside for patients. It's exon skipping in patients with DMD, and we've already enrolled about 54 patients. So then besides this, we are also supporting development of novel viral and non-viral delivery systems for, safe and effective delivery of protein and nucleic acids for therapeutics. And I think most of you would be aware about the efforts the department has with Japan collaboration in the sickle cell anemia, where development of safe and cost-effective genome editing and delivery technologies are being worked out. So these are some of the important initiatives that the department has taken. And I would also like to say that, while I was looking for projects on DMT and spinal muscular atrophy, because that was what was given out in the initial flyer. So I actually could not find many projects ongoing in these two. There are a couple of them on other rare diseases, but there were submissions, but the projects could to the final, cutoff. So I think there is a need to handhold over there. And as everybody else said, that we need concerted efforts. We don't want, one funding agency going their way and another going another way. I think we all have to join hands with clinicians so that we put together all the efforts and patients and patient pool that is available to find out workable solutions. That's all I want to say. Thank you.
Fantastic. Thank you very much for informing all about what the department is doing. Dr. Shastri, can we have your inputs? And then I have one question for everyone. Dr. Shastri, please.
Yeah, thank you, Dr. Khadilkar. I would like to reiterate what others have said. A lot of good points have been mentioned here in this forum. And I would like to say that, a lot of funding agencies are doing a good thing for DMD and SMA by funding a lot of proposals. And the immediate need is that an affordable diagnostics, which will help the patients to get this kind of diseases identified. And also there should be, and I know as a part of the ICMR Rare Disease Registry Initiative or the National Consortium for Rare Disorders, a lot of scientific and medical groups are coming together in a single platform, and this will really enable everybody to go hand in hand and develop affordable technologies which would finally go to the patients. So this is what I would like to say.
Dr. Arun Shastri is the organizing secretary at DART India, which is looking into the dystrophy diseases. I could not introduce at the first. Sorry for that, Dr. Arun Shastri. Any other comments, sir?
No, basically, since I am a clinician, patients talk to me all the time. And one of the tone that I often see is, oh, look, in India, there isn't much research. We will have to find it somewhere else. But when you sit in a meeting like this and when you see what is being done, you see the other side of the thing, that there is much being done. So clearly there is a gap between what is providable and available vis-a-vis what is the awareness. So do you think that also need to be addressed? I think it's an open question to everyone, because the general feeling is that the research potential in our own country is not as much as one would like. Sorry, I'm putting it rather straight. Dr. Jotwani, you want to say?
Yeah, we have huge human resource available in the country. There is a good institutions established, strengthened by all the government agencies. I think we don't lack anything. Yes, of course, the information is not reaching to the grassroots level. And we are working towards that. And I have several proposals for dissemination of all the information and right information to the patient. Please, I would request, मैं सारे जो भी patient groups या patients यहाँ इस panel discussion को सुन रहे हैं, आप ICMR की website पे frequently asked questions आप पढ़ते रहें, जो कि mostly for the new generation technologies के लिए हमने डाले हैं. I have been very proactive. मैंने कोशिश की है और मैं चाहूंगी कि मैं यहाँ सबको being a very the apex advisory body to health ministry, हम चाहेंगे कि इस तरीके की information patient तक पहुंचे कि क्या research हो रहा है. आप यदि हमारी GTAC, that is Gene Therapy Advisory and Evaluation Committee का website है, उस पे हम gene therapy related सारे trials की list भी लगाते हैं, ताकि आपको पता हो कि government approved trial कौन से हैं और कौन सी therapies approved होने जा रही हैं. उसका status हम टाइम टू टाइम रोज ही हम उसको अपडेट करते हैं. मेरी टीम उस पे काफी हार्ड वर्क करती है और इंटरनेशनली क्या इस पे प्रोग्रेस है, कौन सी डिजीज के लिए क्या नया अप्रूवल यूएस FDA ने दिया है या EMA ने, यूरोपियन एजेंसी जो मेडिसिन एजेंसी है, या किसी भी वर्ल्ड के किसी भी कॉर्नर में कुछ नया रिसर्च का आउटकम आया है वो सब हम अपनी वेबसाइट पे डालते हैं। जहां तक जीन थेरेपी सॉल्यूशंस की बात है, ये GTAC पे है। सिमिलर ऐसी तरीके की जानकारी मैं चाहूंगी, मैं डेफिनेटली हमारे लीडर्स को यहाँ कम्युनिकेट करूंगी कि इस तरीके की इंफॉर्मेशन एंड जानकारी फॉर पेशेंट होनी चाहिए। एंड हमारी जो दूसरी एजेंसी है, गवर्नमेंट एजेंसी, उनसे भी उनकी जो एनुअल रिपोर्ट्स, हमारे सबके एनुअल रिपोर्ट्स जो हैं वेबसाइट पे होते हैं। यदि किसी को मौका मिले तो आप एनुअल रिपोर्ट्स के थ्रू जाएंगे तो आपको काफी कुछ रिसर्च पे क्या चल रहा है देश में उसकी जानकारी मिल सकती है। मैं सिर्फ ICMR की बात नहीं कर रही हूँ, DBT, DST सबकी वेबसाइट्स पे ये इंफॉर्मेशन होती है। मगर एक ये जनरल लेमैन्स लैंग्वेज में इसको सब तक पहुंचाना, यस, ये हमारी जिम्मेदारी है और इसकी कोशिश हम जरूर करेंगे और ये मेरा खुद का पैशन भी है।
I think you said it, that it is there, the facilities are there, but people are not aware what is there. So I think we need efforts on that. We're coming close to the end of the panel. We have about 7 or 8 minutes more. So, Dr. Alok, you wanted to say something, and then we probably take one or two more questions before.
Yeah. So, मेरा एक ही कहना है, एक point that हम लोगों ने discuss नहीं किया, वो है कि regulatory landscape हमारे देश के जो drug approval process में होते हैं, वो हमारे landscape में अभी तक regulatory चीजें for variety of things, including gene therapy, it has not been worked out. और पेशेंट ग्रुप से मैं ये कहना चाहता हूँ कि पेशेंट ग्रुप्स की इसमें बहुत रोल्स है, पेशेंट का बहुत रोल है। हम सब मिलके हम लोग काफी कुछ कर सकते हैं। I mean, आप लोगों को सब मालूम होगा एक्सोंडिस 51 का अप्रूवल बिकॉज ऑफ पेशेंट ग्रुप्स के लिए हुआ। इट्स नॉट FDA ने मना कर दिया था, बाद में जाके उन्होंने अप्रूवल किया। हमारे देश में रेगुलेटरी लैंडस्केप नहीं है, वो एक चीज है ICMR एंड सिटीज को मिलके कर सकते हैं। बट मैं कहूंगा कि ड्रग बनके तैयार हो जाएगा, बट इट विल टेक years and years and years to get approved. तो ये चीज के ऊपर हम लोगों को काम भी करना है एंड ये बहुत ही जरूरत है। एंड ऑल्सो बाकी बहुत कुछ है, मैं बोलना नहीं चाहता, देयर इज नॉट एनफ टाइम। ओके,
मैं जवाब देना चाहूंगी इसका। रेगुलेटरी लैंडस्केप इज देयर, हाँ, इंटर एजेंसी कोऑर्डिनेशन एंड कोलैबोरेशन की थोड़ी सी कमी है, मगर वो भी हम पूरी कोशिश कर रहे हैं कि दो एजेंसीज के बीच में एक कोऑर्डिनेशन होना चाहिए। एंड जिसकी वजह से हमने ये जो कमिटी बनाई है, बहुत इंपॉर्टेंट कमिटी है, जीन थेरेपी एडवाइजरी एंड इवैल्यूएशन कमिटी। मगर इस तरीके की और भी ऐसी, जैसे हमने स्टेम सेल से रिलेटेड, क्योंकि हमारा सबसे बड़ा कंसर्न था कि स्टेम सेल थेरेपी बिक रही है इन जेनेटिक डिसऑर्डर्स के लिए फॉर DMD। मैं ये बताना चाहती हूँ कि बहुत सारी ऐसी अनस्क्रूपलस अनैतिक इंस्टीट्यूशंस हैं जो कि ये स्टेम सेल थेरेपी प्रोवाइड कर रही है DMD पेशेंट्स के लिए। बहुत सिंपल अंडरस्टैंडिंग है कि जेनेटिक डिसऑर्डर्स के लिए स्टेम सेल का कोई रोल नहीं है जब तक ये जीन थेरेपी या तो जीन रिप्लेसमेंट, जीन रिपेयर वाली टेक्नोलॉजी जब तक नहीं अप्लाई करते हैं। मगर पिछले 10 सालों से ऐसी अनस्क्रूपलस अनैतिक एंटिटीज इंडिया में कर रही हैं, जिनको रोकने का भी काम हमने हेल्थ मिनिस्ट्री लेवल पे काफी कुछ बोल के, काफी एक्सपर्ट्स पैनल्स ने इस बात पे हमारी लड़ाई जारी है कि इस तरीके का अनमेट नीड जो है उसको इस डायरेक्शन में ना चला जाए कि पेशेंट्स को और उनके पेरेंट्स को कोई इस मिसलीड करें कि थेरेपी अवेलेबल है और उनको इतना पैसे चार्ज करें और पता नहीं जिसका कोई भी साइंटिफिक एविडेंस नहीं है, जो उसकी सेफ्टी का भी एविडेंस नहीं है, उस तरीके की थेरेपीज अप्लाई हो। एंड रेगुलेटरी फ्रेमवर्क में जो भी गैप्स हैं, वो ICMR की हमेशा कोशिश रही है कि उस गैप्स को फुलफिल करने के लिए हमने गाइडलाइंस दी हैं। सो आप ICMR के वेबसाइट्स पे सारे गाइडलाइंस अवेलेबल हैं। हमने यहाँ तक कि डॉक्यूमेंट भी दिया है, एविडेंस बेस्ड स्टेटस ऑफ स्टेम सेल थेरेपीज फॉर ड्यूशेन मस्कुलर डिस्ट्रॉफी और अदर मस्कुलर एट्रोफीज, on ICMR website. और वो पेशेंट्स के लिए है, क्लिनिशियंस के लिए भी है कि क्या आज तक क्या स्टेटस है इसका, स्टेम सेल्स का डीएमडी में, जीन थेरेपी का हम सिमिलर करने की कोशिश कर रहे हैं, बट डीएमडी के लिए स्टेम सेल का कोई भी साइंटिफिक एविडेंस नहीं है। ये हमने बड़े क्लियरली आईसीएमआर के वेबसाइट पे दिया है और इसको हम हिंदी में भी कन्वर्ट करके और जो रीजनल लैंग्वेजेस हैं उसमें भी कोशिश कर रहे हैं ताकि ये दूर दूर तक ये इंफॉर्मेशन पहुंचे। और इसमें कोई भी डेवलपमेंट होती है आगे, पता चलता है कि कोई ऐसी थेरेपी आई है, उसका भी अपडेट आपको आईसीएमआर की वेबसाइट पे इन्हीं चैनल्स में मिलेगा। नेशनल अपेक्स कमेटी फॉर स्टेम सेल रिसर्च एंड थेरेपी, वो एक अलग कमेटी हमने बनाई है जो कि इसको काफी क्लोजली देखती है और गाइडलाइंस बनाती है, ऐसे स्टेटमेंट्स को अपडेट करती है। तो हमने ऐसे 13 डिजीजेज जिसमें बहुत कॉमन स्टेम सेल थेरेपी जैसे ऑटिज्म है, सेरेब्रल पाल्सी है, बहुत सारी ऐसी कंडीशन में जहां स्टेम सेल का कोई साइंटिफिक एविडेंस नहीं है इंटरनेशनली, हम नहीं सिर्फ इंडिया की बात नहीं कर रहे हैं, ग्लोबली देयर इज नो साइंटिफिक एविडेंस, उसका हमने स्टेटस दिया हुआ है आईसीएमआर की वेबसाइट पे। और आप चाहें तो हम एक पैम्फलेट बना के वी विल ट्राई टू क्रिएट अवेयरनेस अमंग्स द ऑल द स्टेक होल्डर्स, पेशेंट ग्रुप्स, क्लिनिशियंस। मुझे लगता है ऑडियो विजुअल्स से भी हमें ये डिसेमिनेट करना चाहिए इन डिफरेंट लेवल्स टू एजुकेट द पेशेंट्स।
Right.
Thank you, sir. मैं कुछ ज़्यादा ही बोल गई हूँ।
No. You made very important points. So I think in the last 2 minutes, I will sort of sum up what we did in the last 1 hour and 15 minutes. Basically, ये जो सेमिनार बनाया था, ये इसलिए बनाया था कि पेशेंट्स को आइडिया आ जाए कि रिसर्च के बारे में क्या-क्या चीजें अपनी कंट्री में होती है, और इसमें काफी सारे एक्सपर्ट जुड़ गए जिन्होंने अपनी अलग-अलग एजेंसीज के बारे में बताया कि एजेंसीज क्या-क्या काम कर रही है। ज्यादातर ये समझ में आया कि जितना भी काम हो रहा है, ये जितना काम हो सकता है, वो आमतौर पे पेशेंट को पता नहीं होता है। सो देयर इज ए डेफिनेट गैप बिटवीन व्हाट एग्जिस्ट्स एंड व्हाट पेशेंट्स परसीव। तो इसको मिटाने की भी कोशिश करने के लिए वेरियस मीडिया का यूज करके वी हैव टू हैव अ चैनल फॉर द पेशेंट। जैसे ये रेयर डिजीज की डायग्नोसिस होती है तो पेशेंट और पेरेंट्स हेल्पलेस फील करते हैं, तो उनको कहीं डायरेक्ट करके ऐसी जगह पर जो ऑथेंटिकेटेड साइट्स है, जो जैसे डॉक्टर जोतवानी ने बताया गलत रास्ते पर नहीं ले जाती है, ऐसी साइट्स को प्रमोट करना इम्पोर्टेंट है। और ये काफी हार्टनिंग है कि काफी एजेंसीज काम करती है अपने इसमें, और हो सकता है कि अपने यहाँ से ही कोई चीज डेवलप हो जो अफोर्डेबल भी हो और जो दुनिया में हर जगह में जाए। So there's nothing wrong in being optimistic. While we face various challenges, let us be optimistic that we will probably succeed earlier than others in trying to do what we can for the rare diseases. And I think it was very useful information exchange for this morning. And I, on my personal count and on behalf of everyone, would actually like to thank Dr. Gulati for arranging this seminar. And with that, I'll hand over to Dr. Gulati. Thank you very much.
Thank you so much, sir, for a wonderful moderation. And thanks you all the panelists. There's some questions which are there. They were just showing me YouTube. Maybe there were some questions. So only there's some, they're asking that they're taking long time from approving. There's a project approval. Dr. Arka project is indigenous. DBT file is there. What next? Dr. Anamika, it's come in the YouTube also and in the main Zoom also. And another one is they wanted to know that the parents wants to give the inputs for assisted technology devices for DMD kids based on the experience and needs. Where should they approach? So the first one, Dr. Anamika, would you like to answer? And
Dr. Shefali would offhand would not be able to tell you as to what is wrong with a particular project and processing, but as most of the people would know that government has now given us a new way of dispersal of funds, wherein everybody is, there's a new accounting system which is called a zero balance account. And I don't know if this is stuck up, the grant is stuck up because of that, because we could not release grants in this financial year, but we will start them shortly as more and more institutions will open their zero balance accounts with the stipulated bank. So I am offhand not aware of a particular project. I won't be able to answer.
Yeah.
But please pass on that question. I will ask the respective division to get back to the PI and give them the correct status.
And some question also for you, Dr. Arun, that why is DART project, although approved, not starting?
We are yet to get some more approvals, so that is why it's getting delayed.
Okay. And Dr. Khadilkar sir, you want to advise the parent who's saying that they want to give an opinion about the assistive technology devices, because they can only, where should they go? Should they go to the pediatric neurologist, or the parent support groups? Because ultimately, something has to be developed, will be by professionals getting projects.
Yeah. I think here, since I work with the MDS of Bombay, I think it's the patient group is a very, very nice platform for this. I think they should throw the question up in the patient group and give their experience. And so often, the patient group experiences are far more practical than what comes through the system. So my suggestion very strongly is that they should put it up in the patient group, discuss it out, and the patient group should be associated with somebody who can help them develop what they think need to be done. And such efforts have already been done before, starting from the sticks for Parkinson's disease to wheelchairs for Duchenne muscular dystrophy. So I think that's the way to go.
Thank you so much, sir. And meanwhile, Dr. Kakuli can post the questions link, the poll questions, and while they're being answered in the next 2 minutes, I would like to extend my thanks to Dr. Satish Khadilkar sir, Dr. Subrata Sinha, Dr. Verma could not join. There was a meeting; he'll join shortly. Dr. Alok, Dr. Geeta, and Dr. Anamika, Dr. Varshni, Dr. Farooq, Dr. Gayatri, and Dr. Arun Shastri. We thought actually that we should have representation and opinion from all sides. And I just wanted to share that, we have to disseminate information. Dr. Geeta, we will, even for that stem cells guideline, which was developed in which I was also involved. You had assigned some task in that. Ma'am, in that, if we can have the gist of that, and we can translate it into Hindi and regional languages, and maybe as a part of this global gene financial advocacy, a very small, just relating only to DMD SMA, ma'am. SMA baad mein banwaya tha, ma'am. Can we just do that? And we'll have to do that in the next 1 week because it's closing. And one more thing I wanted to say, ma'am, one thing, ki, patients, like there are some court cases going on for DMD patients. So they were called to us. I assessed all the DMD patients who came for the court case. To the problem, what I'm trying to share is, there were 2 patients whose children were not amenable to the exon skipping. Still, they were running around with court cases. So I mean that, empowerment of the parents, there are some genetic mutations which are currently amenable, because 45, 51, 53 ka, uske bhi saath mein groups hain. So I think that should be put in public domain. I mean, I'm sharing with my colleagues and my pediatric neurologists all over, and they keep sending me reports, and I tell them this is amenable, you send, this is not amenable. But point is, can we make it somehow, reach out to these parents ki abhi itna ke liye possibility hai, because jiske liye nahi bhi hai wo. Aur dusra, we have to talk about the holistic multidisciplinary care, which we are trying to cover. If you would have seen the list of webinars we have had, and tomorrow after, the second one is on the NGO parent support group, and next then we have the pharma companies from MNC globally and the global scenario, Indian and all. So I mean, how do you think, can we do that? Because nahi to wo dhakke kha rahe hain without being aware. उनको बस एक hope है.
बिल्कुल सही. I mean, you rightly said, and we have Hindi section in ICMR. I'll immediately send that statement to Hindi section, get it translated in Hindi first, and probably they can help us in translate into more languages, and we'll do in the regional languages, and we'll put on the ICMR website.
Yes, ma'am. On DMD SMA, if I can take a bridge version with that, would be the resource for the global gene, so that it is there with your courtesy.
No, if you look at the statement, it is first for the clinician, and the second part is for the patients.
Yes, ma'am. Yes, ma'am.
How patients, you have seen how we have designed that statement, and it is with the help of extensive group, extensive evaluation, and going through the whatever information in public domain, and it's of one of its kind. I mean, when we started ISSCR, International Society for Stem Cell Research, they also put these such statements in the public domain. So I think we can even look at those statements. I can't get translated, but I can also get ISSCR translated, and we can have a very quick statements on different languages for these conditions, and about the mutations and the clinical trials. Exon skipping technologies, for particular mutation, they have got CDSCO approval. It cannot be generalized for all Duchenne muscular dystrophies. So they should be, and it is still investigational. It is not approved. So one should take care when it is under the phase of clinical trial. Nobody can charge patients. So patients को ये ध्यान रखना है, कोई भी जो स्टडी चल रहा है, यदि प्रोजेक्ट है या पायलट स्टडी है या क्लिनिकल ट्रायल भी है, वहां पेशेंट्स को एक भी पेनी पे नहीं करनी है. इट्स इन्वेस्टिगेशनल, इसलिए वहां एथिकली रॉन्ग है यदि पेशेंट्स वहां पे करते हैं. तो यदि कोई एंटिटी उनसे पैसे मांग रही है क्लिनिकल ट्रायल के लिए, ये गलत है. सो एथिक्स पार्ट ऑफ इट इज वेरी इंपॉर्टेंट. जब भी आप कोई रिसर्च करते हैं उसमें ये बहुत इंपॉर्टेंट है कि वहां जहां क्लिनिकल ट्रायल्स में कोई पेशेंट्स पार्टिसिपेट कर रहे हैं तो उनको वहां कुछ भी पे नहीं करना है.
Ma'am, I know, ma'am, वो बहुत exhaustive बना था because you had assigned SMA and cerebral palsy to me for that.
Yeah. So I think we are here, and anytime you need any help, please get in touch. And even the patient groups, they can write to me. We will resolve their queries. We'll help them in understanding. And ICMR, there is another group which holistically working on DMD. So I'm going to join hands with them so that the clinical information can come from them and the scientific information can come from me for the upcoming technologies and new generation technologies.
Remember, Dr. Alok and myself are co-chair for that neuromuscle part. So we are there.
At वहाँ कहाँ DBT के लिए?
ICMR.
Okay.
Actually, I wanted to add one thing because there is a great paper has come out which is going to change the way SMA is treated. Just for your information, this is exon skipping therapy is not great, not working out very well for SMA. Now they have found that an HDAC inhibitor, which is already an approved FDA-approved drug, increases 5 to 10-fold the effect of the exon skipping drug. I mean, and this is already an approved drug. It's a major paper I thought I should share with you. This came out in Cell and it's done by a group. I think this will come out, will change the way this exon skipping works in SMA.
Absolutely.
Yeah, internationally, I don't think they give. I mean, I have discussed it on many platforms internationally in ASGCT and many other forums. I said ISCT. It's exon skipping has not been used. That
It's not being used partly because there was a problem. Now they have come out with this
new. There will be developments.
So add it along with it, and 5 to 10-fold more.
That is nice. So I think we need to work towards that.
Absolutely. Our next panelists have already joined. Last word from Dr. Khadilkar, and then we close this session. And Dr. Charan is already there from the next government disease policy thing.
No, like I said, it was a very enjoyable 1.5 hours, and I'm sure everyone involved learned a lot and also got ideas as to where we should go. So again, thank you very much. Thank you very much.
Thank you very much.
Thank you. I think we'll continue to work together. Thank you.
Yes, ma'am. I'll seek your advice for that pamphlet right now, immediately, and others. Thank you so much.
Thank you, Shefali.
Thank you, ma'am. Thank you so much.
Thank you all the panelists and the participants. Definitely, we need to aim to lower the high cost of treatment of rare diseases with increased focus on indigenous research. That is the message which we got from all the panelists from the discussion, the session which was moderated by Dr. Khadilkar. Over to you, Dr. Shefali.
Sir, if you can stay on for this part, if possible, Dr. Khadilkar, sir, we have the government ready. If you can't, I know I'm grateful to you for
another meeting coming up. I'll try and come back.
Thank you, sir. The same panelist link will work. Thank you very much.
Okay, thank you.
Thank you, everyone. Ladies and gentlemen, we are now moving to the second session for today, which is Government of India Rare Disease Policy. National Policy for Rare Disease was coined in 2021 and is formulated by Ministry of Health and Family Welfare, Government of India. There has been many limitations and its implementation and cost effectiveness and many other advantages and issues are addressed in these policies. Today, for this session, we have Dr. I.C. Verma, Dr. B.S. Charan, Dr. Swati Charan, Dr. Madhulika, and Dr. Vinod Skeria. Dr. B.S. Charan is the Assistant Director General, Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. Dr. Swasti Charan is Additional DDG and Director Emergency Medical Relief at DGHS, Ministry of Health and Family Welfare, Government of India. He leads many national programs on health and related issues. Dr. I.C. Verma is currently the head of genetic department at Sant Gangaram Hospital, New Delhi. He was the main person who had established the genetic division in Department of Pediatrics, AIIMS. We have Dr. Vinod Skeria. He is a senior scientist at IGIB and is a biologist and medical researcher and pioneers in precision medicine and clinical genomics in India. Over to you, Dr. Shifali.
Thank you so much. Dr. Charan, thank you so much for joining. I am just Dr. I.C. Verma was in another meeting. He will join subsequently. And Dr. Madhulika Kabra is the external expert for some PhD Viva. So, sir, it is all your floor till now for all the information. And Dr. Sasti is yet to, Charan is yet to join. I was trying to get, and Dr. Vinod Skaria too. Sir, I'm really grateful to you. You agreed to join. Actually, just to give an overview. So there is a Global Genes is a US-based NGO which has given financial advocacy grant to us. We had Center of Excellence in Advanced Research in Childhood Neurodevelopmental Disorders in Child Neurology Division, Department of Pediatrics, AIIMS. The Center of Excellence is funded by Ministry of Health, as well as funding of CSR from India Infrastructure Finance Company Limited. And when we had put this proposal to Global Genes, तो हमने SMA और DMD पे focus किया था. DMD and SMA are the commonest of the rare diseases, and we have been looking after it for the last. I've been looking after it for the last 25 years in the neuromuscular disorder clinic here. So we were focusing on that, and what we planned was we had planned for a 20 webinar series, and this one is the 8th webinar, in which initially we talked about what are the diagnosis, how do you diagnose, what are the novel therapies and the overall therapies, then multidisciplinary approach जो भूल जाते हैं लोग, plus then what is the new diseases, the new novel therapies के ऊपर we had debate and all. Then we had the debates we also had on the breaking the bad news, transitional care from pediatric to adult, palliative care in very sick patients, talking about ethics of everything, ethics of having expensive drugs available and we are not able to afford, the ethics and destigmatization and humanistic aspect. And abhi last wala panel, the preceding 7th one, was a need for research, and we had people from all over, from ICMR, DST, DBT, IGIB, NIM, HANS, DART, and our own Dean Research and Dean Academics. And Dr. Sadish Khadilkar is a very senior neurologist who's been working on neuromuscular diseases for the last 4 decades. So that, and now this one, what we have is Government of India, what is the rare disease policy and how these patients, can address to, this. So I am, it's all yours. You can, we'll give you the slide sharing thing, sir. I think you can share the slide, right? You wanted to show some slides?
Yeah, thank you, madam, for inviting this panel session. Actually, it was very short time.
Yeah, yes, it was no
information was a bit late.
Yeah.
And
So you can just say like this, sir. It's all. I mean, it's just that we were not planning for slides. I just thought in case you had the one you had on the SMA thing. Otherwise, we just had some questions. You just reply, sir. I mean, I'm really grateful that you could, spare your time because this is for professionals as well as parents. That is why hum Hindi English में we are trying to talk about it mixed pattern में. Sir, so whatever you want to tell about the thing about the rare disease policies and what are the unmet needs, whatever you want to tell, you can minimize, don't show the slide.
Yeah, thank you, madam. Actually, as mentioned in your mail for the panel discussion, so I was not ready for that PowerPoint presentation, but I will be happy to answer, these questions. So we will go by the question. If
Okay, yeah, please show the slides. Yeah. No, sir, we were not making slides. I didn't realize that my colleague was sharing slides. I thought you were trying to share. That's my mistake. Yeah.
Okay.
Yes, sir. Slide दिखाइए. पहले we will start answering. Yeah. And I'm just calling the rest in case. Question
yeah, thank you, madam. Actually, I have your this list of questions.
Yeah.
So basically, I will talk about the mainly the Ministry of Health and Family Welfare and Government of India's part in whatever way for the rare disease, whether it's a establishment of the Center of Excellence or financial assistance to the patient. So coming to the most of some of the core areas pertains to the expert, but yet if you have asked the definition for rare disease, actually National Policy for Rare Disease, this has been notified in March 2021. We called it NPRD 2021. So in that, it was mentioned and it was discussed among the various experts, and the basic criteria mainly they used is the prevalence of the rare disease, though it's not the only criteria. And there are other factors even among, if you see the prevalence for the other countries like US, Japan or other countries, they use the different prevalence rate in context of their disease specific prevalence in their country. So as just right now, there is not a black and white criteria to define rare disease, but yes, prevalence is among one of the major criteria where we define rare disease. And there is a central technical committee for rare disease of the expert, and that committee has some discussion among them, and among set criteria they decide whether we have to include it as a rare disease or not. So coming to that, prevalence is one factor. There are some other factors, availability of the treatment, and whether it's a debilitating disease, how it affects the economy of the individual or country. On that best, disease is defined. So this is basically in brief, how can we say the definition of the rare disease. Can you come to the next question, madam? I think you have given me a list of 8 questions I have with me.
Yeah, they're same questions. So we are just putting on the slide also simultaneously. Yeah. Next.
Your next question pertains to challenges faced in diagnosis and management of rare disease. So I think the subject expert, if you have.
I'm there. So basically, the issues and challenges are, firstly, we don't have any, the awareness is a problem between the awareness of the, between the pediatricians and pediatric neurologists. So awareness is an issue because of early diagnosis is important, especially for SMA. So that is why we are trying to have empowerment of the the parents as well as the all the professionals. So that is why we are having a lot of right now lately we have been having a lot of trainings and all for the professionals to understand how do you suspect SMA, how do you suspect DMD, so that they are diagnosed early and appropriately. The challenge which is the challenge which is coming, the challenge which comes basically is because of, firstly is lack of awareness, and second thing is not understanding when you suspect also what tests to be done. as we have gone in the previous webinar series, when we are suspecting an SMA child, we will have to get an MLPA done. What happens is sometimes in a small child, when we have talked about SMA type 1, छोटा बच्चा है 6 महीने से कम का है, उसमें कई बार वो they will just go ahead and just do an SMN1 deletion, उसमें copy number नहीं होता. If we have to put abhi currently less than 2 years ke bachcho ke liye, we have the humanity global access program available for Zolgensma, in which we put the patient's reports for the lottery, which because every 2 weekly they are taking out lotteries, global lottery, which are anonymized, pata nahi hota ki kiska hai. So we have to put, to usme kya hai, agar doctor will initially, because we are not having time, so if the doctor will do only an SMN1 deletion and do not do an SMN2 copy numbers, so it wastes more time. So that is why the doctor has to suspect early. Then the doctor has also to get the appropriate diagnosis. So that is why we have discussed the protocols which we have developed, and we also, regarding the diagnosis, we have to pick them, suspect early, diagnose appropriately by the appropriate test, and not to waste time. Similarly for DMD also, there is no point going about it. We do the CPK, and then we do the MLPA, and if the MLPA is negative and we strongly suspect, still we have to go and do the exome sequencing, because there are different kinds of, and DMD में ज़्यादा complicated इसलिए है because DMD is got the largest gene, उसमें 79 exons होते हैं, उसमें कहीं पे भी प्रॉब्लम होने में डिलीशन होती है. हमने पहले भी डिस्कस किया, फोटोग्राफ्स के साथ भी डिस्कस किया है, या तो डिलीशन होती है या कोई नॉनसेंस म्यूटेशन होता है, डिपेंडिंग की क्या है कि जो जेन में कहीं पे भी प्रॉब्लम आएगी तो उसके बाद वो प्रोटीन तो बनेगा नहीं. लेकिन क्या है कि ऐसी प्रॉब्लम आई है कि हल्का प्रोटीन बन रहा है या बिल्कुल नहीं बन रहा, उस हिसाब से डीएमडी होता है सीवियर वाला या बेकर्स होता है हल्का वाला. तो बेसिकली हमें सस्पेक्ट करके इनका डायग्नोसिस के लिए इन्वेस्टिगेशंस सही देने हैं. एंड उसके बाद मैनेजमेंट का ये है कि पेरेंट, एक तो डॉक्टर्स की अवेयरनेस की बहुत इंपॉर्टेंट है, और क्या है अभी जो नया है जिसके ऊपर हमने 2-3 वेबिनार्स में डिस्कस किया है कि पेरेंट्स आर चेजिंग द न्यू नोवेल थेरेपीज. बेसिक ट्रीटमेंट फॉर डीएमडी एंड एसएमए इज holistic multidisciplinary management, जिसमें you have to do all the exercise, respiratory exercise, you have to look after the nutrition, you have to look about the orthopedics wala side, endocrine wala side, cardiology wala side, everything has to be seen. So basically वो सारा को देखना है. प्लस जो है SMA के लिए जो 3 थेरेपीज हैं वो डेफिनेटिव थेरेपीज हैं, उनका अलग है जो हम डिस्कस कर चुके हैं और पहले क्लिनिकल वाले पुराने वाले वेबिनार्स में. प्लस जो डीएमडी वाला है उसमें स्टैंडर्ड ऑफ केयर अभी भी स्टेरॉइड्स है. पेरेंट्स लोग स्टेरॉइड्स नहीं देते हैं, लोगों का है कि नए में जाना है. अब ये समझना है कि स्टेरॉइड्स आर स्टैंडर्ड ऑफ केयर बिसाइड्स ऑल दिस एक्सरसाइज, कार्डियोलॉजी और रेस्पिरेटरी सपोर्ट. स्टेरॉइड्स देने से जो है जो डिजेनरेशन हो ही जा रहा है वो उसको इफेक्ट होता है, क्योंकि हमने देखा था कि जो ट्रीटमेंट होता है, अब जब डीएमडी है उसमें वो जीन का प्रॉब्लम है, तो उसकी डिस्ट्रोफिन डेफिशिएंसी है, प्लस ऑनगोइंग फ्री रेडिकल डैमेज हो रहा है, इन्फ्लेमेशन हो रहा है, जिसको भी हम रोक सकते हैं. तो स्टेरॉइड्स का रोल है. साथ में स्टेरॉइड चालू करने से पहले हम लोग जो बोथ हम लोगों को डीएमडी में तो स्टेरॉइड चालू करने से पहले, और वैसे भी एसएमए में भी वैक्सीन प्रिवेंटेबल जो न्यूमोनियाज होते हैं जिसके लिए हम उनको इन्फ्लुएंजा, न्यूमोकॉकल, वारिसेला ये सब हम लोग देते हैं पहले, बिकॉज मांसपेशी में कमजोरी होती है. तो जो निमोनिया प्रिवेंट हो जाए बेटर है, क्योंकि अगर निमोनिया हो गया, अगर मेरे को होता है कुछ प्रॉब्लम तो मैं खांसी करके बलगम करके निकाल देती हूँ, उनकी मांसपेशी में प्रॉब्लम है तो वो प्रॉब्लम रहती है. तो वैक्सीनेशन, मल्टीडिसिप्लिनरी केयर और स्टेरॉइड्स एज स्टैंडर्ड ऑफ केयर इन द डूशिन. एसएमए में मल्टीडिसिप्लिनरी केयर है, उसमें और कोई दवाई नहीं है. वैक्सीनेशन उसमें भी है. और जो ये और है कि बाकी जो डीएमडी के कुछ कुछ चीजों में डेफिनेटिव थेरेपीज हैं. किस में है? जहां पे एक्सॉन स्किपिंग में, या मैं वर्ल्ड ओवर की बता रही हूँ, और या वो नॉनसेंस एक स्टॉप कोडॉन हो गया, जो जीन है उसके वहां पे जो जेनेटिक डिफेक्ट आया, वहां पे एक स्टॉप कोडॉन आ गया ताकि प्रोटीन बनना ही रुक गया. तो स्टॉप कोडॉन आ गया वो वाला, उसके लिए पर्टिकुलर दवाई है एटालुरिन, और दूसरे जो है एक्सॉन स्किपिंग है जिसके लिए 3 दवाइयां हैं, एक्सॉन स्किपिंग फॉर 45, 51 एंड 53. तो क्या होता है, ये नहीं कि वो एक एक बीमारी के लिए, अगर वो म्यूटेशंस तो हैं 7,000 7,500 के करीब हो सकती हैं, तो कुछ अराउंड 100-125 म्यूटेशंस हैं जो ही ओनली एमिनेबल है ये 45, 51, 53 के लिए. तो ये हमें सबको एज पेरेंट्स को समझना है कि सारे डूशेन मसल डिस्ट्रोफी के लिए ये नोवेल थेरेपीज अब भी अवेलेबल नहीं है. अभी प्रीवियस सेशन में हमने देखा कि रिसर्च अनुसंधान जारी है, क्योंकि जो सेम प्रिंसिपल है जो एक्सॉन स्किप कर रहा है, अभी तो हमारे ये 3 एरिया के हैं, तो बाकी एरिया के भी तो बनेंगे आगे ऑन रिसर्च. तो वी हैव टू कीप दैट इन माइंड। और अभी कॉस्ट का इशू तो है ही ग्लोबली, तो अभी बात हो रही थी इस रिसर्च में कि वेदर वी कैन हैव आवर इंडिजिनस थिंग बाय साइंटिस्ट, उसी पे डिस्कशन हो रहा था। बिकॉज अगर हम डीएमडी का कॉस्ट देखें, तो अगर हम कॉस्ट देखते हैं तो एक 30 किलो चाइल्ड का कॉस्ट फॉर थेरेपी एवरी ईयर एनुअल इज 6 to 8 crores बिटवीन द वेरियस ड्रग्स। ठीक है, तो उसके लिए क्या है, वीकली इन्फ्यूजन देना है, लाइफ लॉन्ग नस से इन्फ्यूजन चलेगा वीकली फॉर लाइफ लॉन्ग, एक्सेप्ट एटालुरन जो कि ओरल मेडिकेशन है। लेकिन जो आपका जो एसएमए के लिए जो 3 है, जिसमें जोल्जेस्मा जो है जीन थेरेपी, उसका 16 करोड़ कॉस्ट है। उसमें एक चीज देखने वाली है कि उसमें हम AAV9 वेक्टर में जीन डाल के दे रहे हैं जो आगे जाके बॉडी में प्रोड्यूस कर रहे हैं, लेकिन जो हमारा डीएनए है उसमें इंटीग्रेट नहीं हो रहा है, तो हमें नहीं पता वो कितने साल तक रहेगा। तो अभी जो स्टडी का डेटा है जितना वर्ल्ड ओवर, उसमें है कि 5 साल तक तो उसका रिजल्ट रहता है। 5 साल के बाद भी वो एसएमएन जीन का जो डाल दिया अंदर, वो रहेगा कि नहीं पता नहीं है। एक स्टडी चल रही है 15 साल का फॉलोअप, 2020 से 35 तक। और दूसरा है हमारा जो 2 और दूसरी, ये वाली तो जीन थेरेपी होगी एसएमए के लिए, और जो 2 और नई थेरेपी है, एक है न्यूसिनर्सिन जो रीढ़ की हड्डी में इंजेक्शन लगता है, शुरू में 15-15 दिन के इंटरवल में 3 लगते हैं, चौथा इंजेक्शन जो लगता है वो 3rd और 4th के 30 डेज के गैप में, उसके बाद 4 मंथली लाइफ लॉन्ग लगता है। ठीक है, और जो रिजडीप्लैम एक दवाई है, वो भी जो दवाई है वो ओरली लगेगी, लाइफ लॉन्ग है। जो प्रिंसिपल है न्यूसिनर्सिन वाला जो इंजेक्शन जो रीढ़ की हड्डी वाला और रिजडीप्लैम का सेम है। हमारे मैंने आपको बोला था SMN2 कॉपी नंबर, एक तो SMN जीन डिलीशन है, SMN1 तो मेन है, SMN2 इज अ बैकअप जीन। उसका फायदा उठाया जा रहा है रिसर्च से कि जो बैकअप जीन है उसमें क्या होता है, एक एरिया में एक्सॉन्स जो उसमें कुछ बेस पेयर्स की म्यूटेशन होती है, तो C इज रिप्लेस बाय T, जिससे क्या होता है जो हम एक्सॉन 7 की बात करते हैं वो डिलीट हो जाता है, वो एक्सपेल हो जाता है, जब आगे प्रोटीन बन रहा है, तभी नॉन फंक्शनल पार्शियली फंक्शनल प्रोटीन है। अब जो न्यूसिनर्सिन और रिजडीप्लैम है वो क्या कर रहा है, वो ये कर रहा है कि वो जो 7 को जो निकल जा रहा है उसको निकलने नहीं दे रहा है, ताकि वो 7 अंदर रिटेन करे, जो भी बच्चे में प्रोटीन बनेगा फंक्शनल बनेगा। तो ये उस पे है, और लेकिन लाइफ लॉन्ग है। कॉस्ट का इंपैक्ट हम देख ले तो 16 करोड़ कॉस्ट है जोल्जेस्मा का 1 टाइम, और जो स्पिनरजा न्यूसिनर्सिन रीढ़ की हड्डी वाला है फर्स्ट ईयर में 4.1 करोड़ है, बिकॉज हमारे बोलस डोज थे ना पहले 4, और आगे से 2.1 करोड़ पर ईयर है। और रिजडीप्लाम का 20 किलो के बच्चे के लिए 2.4 करोड़ पर एनुअल था। जब लेकिन इंडिया में लास्ट ईयर लॉन्च हुआ है, रिजडीप्लाम के इज द ओनली ड्रग जो DCGI अप्रूव्ड है एंड लॉन्च्ड इन इंडिया इन जुलाई 2021। वो वाला जो ड्रग है उसका कॉस्ट अब वो उन्होंने पेरेंट सपोर्ट ग्रुप को कुछ एक बॉटल लेके एक फ्री कुछ कुछ करा है, तो 1.4 करोड़ पर ईयर है। फिर भी द कॉस्ट इज टू मच इफ यू सी फॉर अ पेशेंट, एंड दैट इज वन थिंग। तो ये बहुत बड़ी दुविधा है, और ये कॉस्ट का इशू ग्लोबली है। तभी ये पिछले सेशन में था कि वेदर हम इंडिजिनाइज्ड वे में बनाए, बिकॉज ये लोग क्यों कॉस्ट करें। गवर्नमेंट जब हम लोग ये सारे ह्यूमैनिटेरियन एक्सेस प्रोग्राम के तहत तो हम तीनों दवाई दे रहे हैं, हमारे जीन थेरेपी हमारे 10 पेशेंट में हम दे चुके हैं, 2 पेशेंट में देने लगे हैं, जिसमें से मोस्टली ग्लोबल एक्सेस के थ्रू फ्री है। सिर्फ एक क्राउड फंडिंग से हुआ था और एक कोल इंडिया ने दिया था फाइनेंस हमारे पेशेंट को। साथ में जो न्यूसिनर्सिन है ह्यूमैनिटेरियन एक्सेस प्रोग्राम में, पहले हमारे 13 पेशेंट सिलेक्ट हुए थे, 13 और अभी 38, तो हम इतने पेशेंट्स को दे रहे हैं। और रिजडीप्लाम के 9 पेशेंट को दे रहे हैं, जिसमें से 2 क्राउड फंडिंग से हैं और बाकी 7 ह्यूमैनिटेरियन एक्सेस। तो बेसिकली ये इशू है ही, कॉस्ट का तो ट्रिमेंडस इशू है। और एक और चीज बिफोर गोइंग टू बैक टू सर इज, पेरेंट्स सोचते हैं कि ये ट्रीटमेंट से रामबाण हो जाएगा, मैजिकल क्योर हो जाएगा। आई वांट टू जस्ट टेल यू कि उसमें मैजिकल क्योर नहीं है। जो एसएमए के काफी पॉजिटिव रिस्पॉन्सेज हैं, लेकिन बच्चे की माइलस्टोन्स, मोटर माइलस्टोन्स इंप्रूव होते हैं, ओवरनाइट नहीं होते। हमें फिजियोथेरेपी वगैरह कराना, न्यूट्रिशन देखना, आहिस्ता आहिस्ता इंप्रूवमेंट होता है। तो सिनेरियो इज बेटर फॉर एसएमए। डीएमडी में ये देखा गया है स्पेशली फॉर 51 कि जितना टाइम वो चल पा रहे हैं बच्चे, वो थोड़ा सा प्रोलॉन्ग हो, जितनी गति से बीमारी बढ़ रही है थोड़ी सी कम हो जाए। लेकिन जो 53 वाला है उसमें दिखाया गया है कि डिस्ट्रोफिन बढ़ रहा है, उसमें फंक्शनल का उतना नहीं बताया गया। और जो 45 वाला है उसमें सेफ्टी दिखाई गई है, एंड एटालुरिन वाला है उसमें मोटर इंप्रूवमेंट दिखाई है कि डिले हो रहा है प्रोग्रेशन में। पर किसी में दे आर नॉट मैजिकल, मतलब दिस इंफॉर्मेशन शुड बी अंडरस्टूड बाय पेरेंट्स, क्योंकि वो फिर बहुत एंजाइटी स्ट्रेस वो होता है। अब सर ये इधर से था रेस्ट, अब सर आपके डोमेन में what are the how rare disease affect the country's economy and cause a burden on the finance machinery, sir. वो गवर्नमेंट के पर्सपेक्टिव से होगा सर.
Shall I have to continue?
हाँ जी सर, ये सर आप. हाँ जी सर, ये आप ही का.
I think you have elaborated the challenges in diagnosis and management from public perspective. I just want to add that right now there is not only among the general physician, even the at remote places, awareness in pediatrician also there is a need, and right now we don't have the recognized DM courses in the medical colleges. And then comes, if we see at our peripheral health system, at the central health CHC, community health center or district hospitals, where there is not the, many posts of the even pediatricians are vacant. And for the diagnosis of these rare diseases, the machinery and equipment are not available to such extent. Our country is a very vast country and catering, so much of population. So that again puts some challenge in diagnosis and management of the rare disease. So I will not go in detail of question number 2. You have very well covered this. Now coming to the question 3, how dare disease affect the country's economy? So it's indirectly, yes, it's a debilitating disease. So every life lost is whether it's a disability or death is an economic burden, as well as financial aspect. Coming to the health system is already constant. Our GDP expenditure in health is already very limited, and though repeatedly it was suggested that we should have our GDP at least 4 to 5% on health sector, but for the past couple of years, or even if I'm not wrong, for the decades, it is not more than 1.2%. So health system is already resource constant and competing priorities, and among them, this rare disease, as you correctly pointed out, Zolgensma, which costs around 16 crore for the one patient. So from public health point of view, it is very difficult to convince even the policymaker that you are spending 16 crore for a single patient, and even in that patient you are not sure. So that's indirectly, it's a burden, but we cannot deny health is as per the constitutional, right, fundamental right, but we have our resource limitation. So I think there are some steps, financial assistance from the government, various state scheme, as well as the crowdfunding and bargaining with the purchase of the drugs. So that will, I think, in the coming time will solve this issue. So with this, I finish this question 3, and if I come to the question number 4, what is the role of various center of excellence and Nidan Kendra developed by the government of India and rare disease policy? Yeah, that part is comes under the purview of the GOI, MOHFW. So government of India is supporting the states through these center of excellence for rare diseases. Right now there are the 8 established center of excellence, and we are in a process to expand this list. So existing 8 center of excellence, they have given the responsibility for diagnosis and management, and there are some provision for financial assistance, like one time support of 5 crore to COE for establishment of for procurement of some machinery and equipment. There is provision for consumables, and through these center of excellence, other financial assistance to the patient will be provided. In addition to that, center of excellence will be the first contact point for diagnosis as well as the management, and for creation of training component, capacity building of the health workers, and for in a particular state it will be the nodal center for compiling or to find out the exact prevalence or number of the cases. So government of India, whatever is doing through the center of excellence. So it has a major role. Coming to Nidan Kendra comes under Ministry of Science. So DBT has established these Nidan Kendras, and role of Nidan Kendra is supportive in rare disease in addition to their other tasks. They help in the the counseling part, in providing some equipment, some HR. So in that way, they are helpful for the rare disease. So I think with this, I complete this question. For if any question, then I will be happy to answer. And otherwise, ma'am, you can.
Okay, next one. Yeah, sir, actually, previous session में डॉक्टर अनामिका ने बताया था कि उनके अभी उन्हें निदान केंद्र भी है और साथ में उनके उम्मीद सेंटर भी है जिसमें डायग्नोसिस के लिए उन्होंने 15 अभी बन गए हैं और 45 बन रहे हैं, तो गवर्नमेंट की तरफ से तो डायग्नोसिस के लिए भी हेल्प है. सर, नेक्स्ट क्वेश्चन इज हाउ डज GOI प्रोवाइड फाइनेंशियल असिस्टमेंट फॉर ट्रीटमेंट ऑफ रेयर डिजीजेस. ये एक बहुत बड़ा इंपॉर्टेंट मुद्दा है एंड उसके ऊपर बहुत टेंशन है पेरेंट्स के अंदर, तो इसके लिए.
Yeah, thank you, madam. So, as per NPRD policy and now the guideline and procedure for giving financial assistance to the patient, this has also been issued by the ministry. I think, as you said, madam, some parents have also joined this meeting.
So, sir, this is being live streamed in YouTube, sir. वो YouTube में है.
Yeah, I got it. So, I think it's a very the government of India, and there is some clarity, though I would say there is a ongoing discussion on this also, and over a period of time, there will be a new development. But as of now, government of India is providing financial assistance to the rare disease patient, and this capping is 50 lakh rupees per patient, and all this financial assistance will be through the Center of Excellence. So, आपका पर पेशेंट, किसी भी पेशेंट जो रेयर डिजीज का पेशेंट है, उसके लिए गवर्नमेंट ऑफ इंडिया की तरफ से इररेस्पेक्टिव ऑफ वो उनका इकोनॉमिक क्लास कौन सा है, और वो एज पर एनपीआरडी में जो ग्रुप 1, 2, 3 डिजीज दी है, इररेस्पेक्टिव ऑफ दैट ग्रुप, आप किसी भी इकोनॉमिक क्लास से हैं या कोई भी ग्रुप की आपकी डिजीज है, अगर आपका रेयर डिजीज एनपीआरडी में जो एनेक्सर 1 दिया है उसमें अगर नोटिफाइड है, तो हर पेशेंट को 50 लाख रुपए का सहयोग जो है वो फाइनेंशियल असिस्टेंट गवर्नमेंट ऑफ इंडिया ने पेशेंट को दी. और ये असिस्टेंस जो एस्टैब्लिश सेंटर ऑफ एक्सीलेंस है, जो कि अभी 8 है, और इनके एक्सपेंशन का, इनको बढ़ाने का जो है वो प्रोसेस चालू है. ओवर ए पीरियड ऑफ टाइम आपके सेंटर ऑफ एक्सीलेंस उसमें जुड़ेंगे. एम्स जोधपुर हमने अभी विजिट किया है. केरला में आपके सेंटर है, त्रिवेंद्रम कहिए, कोट्टयम या कोझिकोड. चेन्नई जो है वो है, और जिपमर है. इसमें टीम ने विजिट किया है, एंड वेरी सून इनमें भी आपके सेंटर ऑफ एक्सीलेंस एस्टैब्लिश होंगे जो एग्जिस्टिंग 8 है उनके अलावा, प्लस भोपाल, पटना, भुवनेश्वर, रिम्स, इनमें भी योजना बनाई जा रही है जहां सेंटर ऑफ एक्सीलेंस होंगे. तो ये फाइनेंशियल असिस्टेंस 50 लाख रुपीज आपको सेंटर ऑफ एक्सीलेंस जो एस्टैब्लिश है रेयर डिजीज के लिए, वहां आपको पेशेंट को रजिस्टर करना है, और वहां जो डॉक्टर हैं वो असेस करेंगे, और अगर वो रेयर डिजीज के पेशेंट है तो पेशेंट को अपना एक जो फॉर्म दिया हुआ है वो फॉर्म भर के वहां के जो डॉक्टर उनको देना है, वो डॉक्टर फॉर्म को फिलअप करके, हर सेंटर ऑफ एक्सीलेंस में एक कमेटी रहेगी, वो कमेटी के रिकमेंडेशन पे जो असिस्टेंस गवर्नमेंट ऑफ इंडिया से मांगी जाएगी, और गवर्नमेंट ऑफ इंडिया उस केस में आपको असिस्टेंस देगी. ये आपके जब सेंटर ऑफ एक्सीलेंस आपका रिकमेंड करेगा, तब से आगे के ट्रीटमेंट के लिए पुराना कोई रिम्बर्समेंट इसमें शामिल नहीं होगा. और दूसरा, जो पेशेंट किसी भी गवर्नमेंट स्कीम में अगर कवर्ड होते हैं, सेंट्रल गवर्नमेंट की या स्टेट गवर्नमेंट की या PSU, वो ऑलरेडी किसी स्कीम में है, तो उनको इसमें शामिल का प्रोविजन नहीं है. अदरवाइज इसमें बाकी सारे लोग जो हैं वो शामिल है. तो आई थिंक आई हैव कवर्ड दिस गवर्नमेंट ऑफ इंडिया फाइनेंस असिस्टेंस पार्ट.
Yes, sir. In what way the national policy for rare diseases has boosted the research and development of drugs for rare disease like DMD, SMA? तो उसके लिए I would request Geeta Jotwani ma'am. Ma'am, would you? Ma'am, I know you. Ma'am, you're there. Ma'am, I know you were not. I didn't request you for this panel, but because you were there, I'm requesting you. Ma'am? Okay. I think I'll tell, there has been, there's lot of, अब इसी के बाद, अभी जब वो DMD के, जब इसके बाद अभी DST में भी हमने सुना, DBT में भी सुना, एंड DBT के अंदर उन्होंने वो उम्मीद है, और फिर वो निदान केंद्र की है। अभी ICMR के अंदर इन्होंने इतना पूरा रेयर डिजीज कंसोर्शियम बनाया है, उसके रेयर डिजीज कंसोर्शियम बनाया है, जिसके लिए उसके अंदर उसके अंदर डिफरेंट ग्रुप्स हैं। उसके अंदर एक जो ग्रुप है पूरा रेयर डिजीज वाला, उसके अंदर एक न्यूरोमसल ग्रुप सेपरेटली है। न्यूरोमसल ग्रुप के अंदर उसके अंदर डॉक्टर आलोक जो पिछले सेशन में थे वो और मैं को चेयर है, और उसके अंदर डिफरेंट मीटिंग्स हुई हैं फार्मा के साथ, पेरेंट सपोर्ट ग्रुप्स के साथ, एंड ये पूरा एक डॉक्यूमेंट बनाया है कि कैसे उसको रिसर्च करना है। और एक रेयर डिजीज रजिस्ट्री है ICMR की, जिसके अंदर उसमें रेयर डिजीजेस जिसके अंदर न्यूरोमसल भी है। एज ऑफ नाउ न्यूरोमसल जो डिजीजेस है उसमें SMA, DMD और LGMD का ही वो रेयर डिजीज रजिस्ट्री में है। that is how matlab that I think the research has lot of matlab been boosted a lot. And Madhulika ma'am, thanks for joining. मैंने बता
sorry, I was in another meeting, so
नहीं, मैंने बोला
sorry. Yeah.
मैंने बोला था कि आप वाइवा ले रहे हैं PhD का। मैम, thank you for joining. Dr. Charan is here and we have discussed certain things till now. तो मैम इसमें maybe आप can you please just tell about anything about the whatever is leading to the rare diseases and the role of the Center of Excellence and the main committee things. Like we have covered the definition of rare diseases, and but what all covers under the purview of rare diseases, you may add on to in that, and how you have conceptualized from the Central Technical Committee and the various things, and other coming to the Center of Excellences. Dr. Charan has told from his side, but ma'am, from your side, being in the from the inception and center, yeah.
Yes, Shafali. So thank you for involving me, and I'm sorry for not being there on time. So as Dr. Sharan must have already told you, the rare disease policy, the revised one, came into picture in March 21, and we are all sort of moving towards the implementation in the best possible ways. So basically, these 8 centers of excellence which have been identified by the Ministry of Health and Family Welfare, and more are in process and are being sort of, they are being evaluated for being included further. So basically, the centers of excellence have multiple roles. It is not only for early diagnosis and management of these babies. So there's the rare diseases, not only babies, because these patients can be from any age. So facilities for early recognition and diagnosis, and then management, which whatever is available, specific, and in most of the time it is more of supportive management only. And then and very importantly, I think, how to make treatment available for these patients. And lots of efforts are going in that, how because some of the treatments are very, very expensive, and there are modalities which are being worked out by the ministry, but the hike of the RAN limit, which is now 50 lakhs, has really come up in a good way, and maybe many of these patients we would be able to help. Then another component of the centers of excellence is the increasing awareness, not only amongst the clinicians, it is also amongst the general public about the rare disease. And it is really become, it has improved significantly in the last 4-5 years. And the other thing is that we also need to have research component also in the centers of excellence, and the areas are to be chosen which are the important areas of research which have to be worked on, particularly in our country. And there are many task forces which have been formed, and one of that is in the ICMR, where the areas for research in the rare diseases which are important in our country are being worked on. And then very importantly, another important component for all the centers of excellence is the counseling and prevention aspects also. So beginning from early identification, diagnosis, increasing awareness, managing these patients with specific therapies, and very importantly, providing supportive therapy, which are often neglected, then going on to the research and also the preventive aspects. So these are the various aspects. Then the inclusion of diseases, if you see the rare disease policy, they have been included, the groups, 3 groups have been divided. And earlier it was like one-time treatment where most of the stem cell transplantation diseases were included. And then you have the second group where the cost is not as high as say for enzyme replacement therapy or treatment for neuromuscular disorders. This included the PIDs and also the groups like where small molecule diseases where the specific diets are required, and immunoglobulin therapies and some other therapies. And the third group is the most expensive one where ERTs and the newer therapies, particularly for neuromuscular disorders. But this was just based on the availability of some kind of therapies or in the pipeline available at that time. So the list is not restricted to these groups of disorders only. There have been applications to the Central Technical Committee, as Shefali was referring to, and all disorders with which the applicants come are scrutinized by the committee, try to find out whether it is actually rare, and if any specific requests are made for therapy or specific treatment, then they are considered. So this is a misconception that that list of diseases which is given in the rare disease policy is sort of is that list only. It can go beyond that because the rare diseases are more than 7,000, and nowadays treatment for many of these are coming up. So I think this question has been asked many times, that why are this particular disease is not included in the rare disease. So there is a big group of others, and any other disease which is rare and for which some specific therapy is available can be considered under the rare diseases. So that's what from my side, Shefali, as of now. Thank you.
Thank you, ma'am. And what are the various strategies for implementation of the policies framed under this national policy for rare disease? What are the various strategies? I think Dr. Charan and then ma'am, Dr. Madhulika ma'am. Dr. Charan?
Yeah, thank you, madam. So I think ma'am has correctly elaborated the role of the COEs. So as per NRD, those aspects are covered on the rare disease. So implementation comes, so it's mainly through the Center of Excellence, and Center of Excellence has, multiple roles, not only limited to the diagnosis and managed part of the patients. So through establishment of COE, this implementation of NPID is the one of the major, implementation strategy. And in addition to that, expanding the Center of Excellences, more and more Center of Excellence will be created for the easy accessibility and regional outlook. So that is one strategy. In addition to that, for financial assistance, is guideline has now also been issued. So this is financial assistance to the patient for the treatment, that is also through the COE. And if crowdfunding portal that has been created for the voluntary donations. And now the new development that we will encourage the corporate sector and other companies with the help of Ministry of Commerce and Industry to promote that funding through CSR. So there are procedure for planning a meeting with all these corporate houses. Then comes ma'am, creation of the ICMR registry. So what is the exact prevalence of the disease? So we are working on that, and there is some development on that, but it will require some time, and we will include most of the state government run hospitals, and over a period of time private hospitals. So exact burden will be we'll find out. And in addition to that, there are some activities for the research part also, as well as in collaboration with the CDCO. Some drugs have been made this custom free, duty free, and some bargaining if we purchase it on large scale. So these are the various activities, and I think there is a lot to do because it's a new area. So I think I have covered the major areas, major way by which we implement this NPRD. Up to you, Madhulika madam, if you want to add some.
Madhulika ma'am? Ma'am, mute. You are muted. Ma'am, you are muted.
For implementation based on the AIIMS which have been given to the centers of excellence. say starting from say early diagnosis and management of these patients. So as I said, it is being worked out by the Ministry of Health that what facilities are available in these centers of excellence and what do they need more to take care of these say diagnosis and other issues. So for this, this is being worked out, and one-time grant for equipment which are based on the gap analysis which they have in their institute. A grant of rupees 5 crores will be given by the center to sort of strengthen these centers of excellence. And also there is a move for giving some consumables also if required for diagnosis, so that the cost issue doesn't come into picture. And I mean, can be taken care because many of these tests are quite expensive. For the and for other like awareness and things like that, through the MOH and the centers of excellence, they have to do it themselves based on the strategies for building up awareness. And then I think importantly, for treatment, it has already been said by Dr. Sharan, one is the step of increasing the cutoff to 50 lakhs, which will help at least some of the patients, if not for the very expensive ones. And the other thing is through portal. I think the portal one really needs strengthening, because awareness regarding that and more dissemination regarding the CSR and donations through the portal will be useful for the group 3 disorders where the treatment is very, very expensive. So that's what I wanted to add, Shifali. Thank you.
Thank you. Thank you, ma'am. And then there is any national policies or guidelines for diagnosis and management of DMD and SMA. Ma'am, as ma'am, we were making those guidelines, which abhi, I mean, the guidelines for DMD and SMA, we were making here, and ma'am, under your supervision when we were making, and then I think we have just as of now we have just made for DMD new drugs, which was sent to the Central Technical Committee, and uh, others, the multiple holistic care of DMD and multiple holistic care of SMA and the drug therapy for SMA, they are yet to be approved by the Central Technical Committee. So ma'am, that's not where we stand now. Ma'am, only the DMD ones which were there, which were approved, which I had presented to the Central Technical Committee. So as of now, there are no specific ones available except there, and it was also discussed because the study which अभी मैंने पहले भी mention किया था कि studies are ongoing और लिटरेट कई चीजों में सब्सटेंशियल एविडेंस है, कईयों में नहीं है, तो इसीलिए these guidelines will be dynamic, मतलब periodically they will be re-evaluated by the subcommittees who are looking after, like we're looking after the neuromuscle part, so they'll be re-evaluated by the whole committee periodically, maybe annually, so that कोई भी नया evidence आया उसकी वजह से वो update हो जाएंगे. So this one we have to keep in mind. So there are some questions which we have. Should we take the questions before you give the final messages? एक तो था कि मल्टीडिसिप्लिनरी अप्रोच में कह रहे हैं कि गायनेकोलॉजिस्ट को इन्वॉल्व होना चाहिए. वो मल्टीडिसिप्लिनरी अप्रोच नहीं है, वो जेनेटिक काउंसलिंग एंड प्रीनेटल डायग्नोसिस है, जिसके बारे में बार बार बात हो रही है हमारे पिछले वेबिनार्स में भी. मधुलिका मैम, यू लाइक टू मेंशन, वो किसी ने अभी स्टार्टिंग में ये लिखा है कि मल्टीडिसिप्लिनरी अप्रोच की जो हम बात कर रहे हैं उसमें गायनेकोलॉजिस्ट को भी इन्वॉल्व करना है. तो वी हैव टू हैव ये मतलब क्लियर है कि अगर एक फैमिली में 2 बच्चे इफेक्टेड हैं डीएमडी SMA या कोई भी जेनेटिक डिजीज के, तो हमारी मेडिकल फ्रेटर्निटी का पूरा फेलियर है. मैम इसका
Yeah, I totally agree, Shefali. So it has to begin. Yes, obviously, if we are talking of screening, early screening, newborn screening, and all, then it starts from the antenatal period, and the counseling, particularly for high risk mothers which are at high risk for genetic diseases, they would be picked up by the obstetricians and gynecologists, followed by then in the neonatologists and the pediatricians, and then obviously it is very important. So I think it has to be, we have to be, all of us have to be together, because as you are aware, genetic disorders are across disciplines. It is not that it is restricted to pediatrics. Most of them would present in the pediatric age group, that's different, but then it is so everybody has to be aware regarding this, and the multidisciplinary approach is the crux, because that is lacking. And that's why we always emphasize emphasize to the patients that even if there is a specific therapy available without the multidisciplinary approach, supportive therapy, rehab, PMR assistance, it will not, the specific therapy is also not going to work. And then in search of a specific therapy, parents many times do not give any importance to the supportive therapy and the multidisciplinary care. So I think at all levels, it has to be emphasized. Thank you.
Thank you, ma'am. Next question है कि is the financial assistance only given for the medication or even the assisted aids like power wheelchair, respiratory units like BiPAP or tyrology or as required with DMD kids? मैम वो हमें अभी होलिस्टिक वाला वो गाइडलाइंस बनाई नहीं तो
उसके लिए we need some clarity that in this 50 lakh, Dr. Charan may be able to tell us that in this 50 lakh, what all can be included. So for supportive care also, can this be included or not? There is, because it's just come in, so there are some clarifications required for that.
And Dr. Charan, दूसरा क्वेश्चन भी साइमल्टेनियसली लिंक्ड है. वो बोल रहे हैं कि बच्चों की फिजिकल थेरेपी के सेशन होते हैं ना, तो उनका भी क्या इसमें इंक्लूडेड है? सो बेसिकली द क्वेश्चन ओवरऑल विल बी कि सिर्फ मेडिसिन के लिए है या असिस्टिव एड्स लाइक पावर व्हीलचेयर, रेस्पिरेटरी यूनिट जो थोड़ा वेंटिलेटर टाइप बाईपैप वगैरह है, और फिजिकल थेरेपी के जो सेशंस होते हैं उनके वो पेड, वो सब में आता है कि नहीं? Want to clarify.
Right now, the financial assistance is mentioned as the for the treatment part. It has not the clarity on the subdivision. But what I think, and we will discuss this issue. A meeting has been planned, and soon we will get the answer on it. But till now, it has been mentioned for the treatment. So it comes under the purview of the treating physician. Like this post for the physical activity. So physical activity is a component of the treatment. So if it is recommended by the treating physician, ministry will approve that required only 3 documents. What patient has given in Annexure 4, his request for financial assistance, and then doctor's evaluation, and third, there will be a committee at each COE. So that committee's recommendation for the treatment part. So if that treating physician decide the cost division, and if he mention maybe this supportive equipment parts or post for the physical therapy, and the committee recommend this, ministry will not have any issue. But for the clarity purposes, we again will include this in our discussion part, and we will get the clarity. So I think till 8% we will restrict that it is for the treatment part, and treatment will be decided by the treating physician. So we are not saying clear no, but yet for the yes, it will be discussed, and we will get the clarity on that. Thank you.
Thank you.
As we are discussing with the questions with the panelists, we will start the poll also. It is requested to all the participants to kindly go with the polls.
अभी एक क्वेश्चन आई हैड आस्क्ड and Dr. Geeta उस समय उनका म्यूट था. Ma'am, this I would like you to answer in what way national policy for rare diseases has boosted the research and development of drugs for rare diseases and other other advances in the management for DMD SMA specifically.
Yeah, so as per the directions of Health Ministry, ICMR has established quite a few programs for rare diseases. The first one, which we started with the Registry of Rare Diseases, and which has now been implemented, and the registry projects are already ongoing for 5 different groups, what I understand. 5 different registries are there for neuromuscular, for hemoglobinopathies, for many more rare diseases. Similarly, a national consortium has been established for the research in rare diseases, where I think ICMR has been spearheading that, and the consortium has been established where drug development is also one of the key areas. So what are existing drug standard treatment protocol? Along with that, what new drugs can be brought in? Again, the biosimilars, what we say, I always say that India is very good at biosimilars. So if these drugs can be developed indigenously, which are not affordable, that would be a very important thing for the country. So to make it more affordable, because I was listening to your discussion, and even if the 50 lakh package is provided, they are still struggling that whether it can be used for drugs or for the basic needs for the patients like wheelchair and physiotherapy and all. So this is a big question, and I think patients, the parents always have question before them that आप ये 50 लाख का यदि पैकेज अनाउंस होता है तो वो किस चीज के लिए है? I think most importantly it should be drugs, and of course other things are equally important that I think probably we need clarity on that. So drug development पे research तो हो रहा है, but those which are rare diseases we don't know any what drug can be effective unless until we know that these drugs are available and these are scientifically known that are effective for these conditions. Those drugs can be very well been, and repurposing of the drugs, the research is on. So there is a lot of research needs to be done on this front, and I think under this consortium we have started a task force also. Dr. Madhulika is aware of that, and many more people on the panel, they are aware that there is activities, research activities in rare diseases is the forte of ICMR, and they are doing quite a bit in this front. And of course, new generation drugs that I am looking after, which covers all unmet needs and including rare diseases. We have even a virtual center for molecular medicine with focus on rare diseases, which is a consortium of 7-8 centers in the country, leading centers, those who are working on different research activities, research aspects of rare diseases. So in which I think SGPGI, AIIMS, then as KMC, CDFD, CCMB, Reddy's, and many more centers are involved, and that virtual center is at the verge of establishing now. So we have many activities at ICMR for rare diseases as per the direction of Health Ministry. So I think we are working on drug development, but unless until we know what are the drugs which are scientifically proven for certain diseases, yes, indigenous development is very important for that.
Thank you, ma'am. Thank you so much. Now we are at the end of this session. I thank Dr. Charan, Dr. Madhulika, and Dr. Geeta to have joined the panel. Dr. Charan, can you give your last messages, sir? Final message.
Thank you, madam. I think it's a wonderful platform to discuss and know from the parents aspect or जो उनका requirement है कुछ जो है. So I think it will help in in our subsequent meeting we will raise those issues. Yes, along with the treatment, basic needs of the patient that should be covered in that care. So we may have the recommendation for that, and I can only inform through this platform that now the expansion of the Center of Excellence is on the priority basis, and soon the access will be easy for the rare disease patient, as well as ma'am has pointed out, regarding research, registry, and new drug development. So that will help in in existing what we are doing in NPRD. So that's all from my side. Thank you.
So before I ask Madhulika ma'am, 2 questions और है. Doctor, if the DMD patient takes medication for heart की cardiomyopathy, is it covered? Sir, वो तो treatment है तो covered ही होना चाहिए ना?
Ma'am, all treatment, whatever is suggested for the financial assistance is through the treating physician of the COE. If treating physician of the COE recommends whatever is mentioned there, it will be considered. So yes, it's not a question of CADA or whatever.
But point is कि medications तो clear है sir, पर वो है कि अगर devices जो assisted devices है और therapies है उसका principally देखना पड़ेगा, है ना? Sir, वो आप लोग decide करेंगे in the meeting, है ना? Sir, एक और question है, suggestion है. If teleconsultation could, Madhulika ma'am, it will be important for you also to hear this question. If teleconsultation could be available in centers of excellence, that may solve the problem of transportation, which is a major problem for these patients जो non-ambulatory हो जाते हैं. So that is there. टेलीकंसल्टेशन इज इम्पोर्टेंट, यस. तो एक लेवल पे आई थिंक वो है. हमारे यहाँ पे चाइल्ड न्यूरोलॉजी का टेली कंसल्टेशन, टेली हेल्पलाइन सर्विसेज है फॉर द लास्ट नियरली 5 years नाउ. तो उसमें वी आर आस्किंग देम टू सेंड द इवन जो वीडियोस ऑफ द पेशेंट्स एंड द द रिपोर्ट्स, ताकि हम बता देते हैं कि उनकी अभी करंट वाली एडवांसेस में अमेनेबल है कि नहीं. पर अगर वो पूरी कंसल्टेशंस कर पाए कि नहीं. मधुलिका मैम, योर कमेंट्स प्लीज.
Shefali, can you just repeat the question once?
हाँ, मैम वो कह रहे हैं कि टेली कंसल्टेशन अगर हो जाए सेंटर ऑफ एक्सेलेंस से, तो उनको मतलब जो ट्रांसपोर्टेशन का प्रॉब्लम है वो कम हो जाएगा.
Yeah, definitely. So it can be done, and as Shefali said, our neurology division is really actively doing it. And during the COVID times, actually this has come up, and we do teleconsultations. We can even evaluate the patient with the help of another clinician who's looking after. And if some samples are to be sent, sample transport is easy, primarily for DNA-based testing and all. They don't get, unless it's very hot, it's quite okay to transport samples. So this can definitely be done, and this would avoid travel and cost also for the patients. I totally agree, Shefali.
मैम, और दूसरे वो है जो हम लोग ने ये सेंटर ऑफ एक्सीलेंस इन एडवांस रिसर्च चाइल्डहुड न्यूरो डेवलपमेंट डिसऑर्डर जो हमारा मिनिस्ट्री ऑफ हेल्थ से स्पॉन्सर्ड है विद IFCL सपोर्ट फ्रॉम CSR फ्रॉम देयर. उसके अंदर हमने अप्रैल 2018 से शुरू किया था, बिकॉज ये सारे न्यूरो डेवलपमेंट डिसऑर्डर्स हैं एंड और न्यूरोलॉजिकल क्रॉनिक डिसऑर्डर्स हैं, दे आर अक्रॉस द लाइफ स्पैन. तो पेरेंट्स इतना एब्सेंटिज्म बच्चे का और पेरेंट्स का मुश्किल,
I totally agree.
रिस्पेक्ट से किया था. एंड इवन राइट नाउ पूरी इंडिया से ना दे सेंड द जेनेटिक रिपोर्ट्स ऑफ द DMD पेशेंट on WhatsApp, and then we tell them कि वो अभी amenable है कि नहीं. अगर amenable है तो then we call them right now for their forms. Otherwise there is no point कि दूसरी जगहों से आए, है ना मैम?
हाँ, बिल्कुल. Travel, unnecessary travel. Yeah.
Ma'am, your final comments.
Okay, so thank you very much, Shefali, this platform is really, really useful, holistic, and involves clinicians, experts from all the areas, and the patients also. So it is really, really good to have this. So my message for patients who have rare diseases, मैं यही कहना चाहूंगी कि अभी बहुत कुछ हो गया है हमारी कंट्री में रेयर डिजीज के बारे में लास्ट कुछ सालों में, और सभी की तरफ से बहुत एफर्ट्स चल रहे हैं, सारे इंस्टीट्यूशन, सारे डॉक्टर्स, और इम्पोर्टेंटली मिनिस्ट्री ऑफ हेल्थ से, और हमारे सारे जो रिसर्च सपोर्ट इंस्टीट्यूशंस हैं, जैसे मैम है यहाँ से ICMR से और दूसरे हैं, तो सभी लोग कोशिश कर रहे हैं कि इस एरिया में काम किया जाए. सिर्फ रिसर्च के लिए नहीं, पेशेंट केयर पे बहुत ज्यादा एम्फेसिस है, और ये कोशिश किया जा रहा है कि जितना मदद हो सके पेशेंट्स को हर एस्पेक्ट में दिया जाए. तो मुझे लगता है हमें आशा रखनी चाहिए, और आई एम श्योर कि कुछ ना कुछ जरूर होने वाला है और हो रहा है, और आगे बहुत अच्छा होगा. एंड वी ऑल हैव टू जॉइन हैंड्स टुगेदर टू केयर फॉर रेयर. आई थिंक दैट्स द मोटो विच वी ऑल शुड हैव, एंड सबको साथ काम करना पड़ेगा, पेरेंट्स को, पेशेंट्स को, डॉक्टर्स को, मिनिस्ट्री को, हम सभी लोगों को मिलकर काम करना पड़ेगा, और मुझे पक्का विश्वास है कि हम इस एरिया में बहुत अच्छा काम कर पाएंगे. थैंक यू वेरी मच. थैंक यू
मैम. और एक और चीज है, अब नेक्स्ट मीटिंग में ना डॉक्टर चरण आप ना वैक्सीनेशंस का भी कर दीजिएगा, बिकॉज हम ये DMD SMA के पेशेंट्स को वैक्सीनेशंस देते हैं, वायरसेला, इन्फ्लुएंजा, न्यूमोकॉकल. तो अगर वो भी कवर हो जाए ना, तो मैम दैट कैन बी डिस्कस, ताकि उसमें कोई ऑब्जेक्शंस ना आए. हम तो यहाँ से लिख देंगे, पर अगर दूसरी जगहों पे वो हो जाए ताकि उनके लिए आसानी हो जाए. डॉक्टर गीता मैम, would request you for final comments, and thank you for have stayed on into this panel too, please.
Thank you, Shefali, and it's a wonderful platform. I really enjoyed these 2 sessions of discussion, bringing everyone on the platform and discussing all the possible aspects of what is required, and involving all the stakeholders here is very important. And I think this activity needs to be continued, and definitely to educate patient groups and making them understand, and also at the same time hearing from them that what are their problems is very, very, very important. And I really agree with Dr. Madhulika that koshish चल रही है और इस कोशिश में हमें आप सबका साथ चाहिए and I think we are here to help each other to lead to some achievements in this on this front.
Thank you.
Thank you, ma'am. और ये ना orphan शब्द थोड़ा अच्छा नहीं है. I have a strong objection to orphan शब्द being used globally. And point is ये जो rare है, but they need more care. So I think we all are there, and I'm really grateful, Dr. Charan, with no notice. Actually, that was practically no notice. I requested you. I'm really grateful to Dr. Madhulika and Dr. Geeta, and to all of you. And all these are live streamed on YouTube and will be available. All the sessions, all the 20 webinars, and they'll be on YouTube in a pairs of 2 because we have 2 webinars every day, and we'll be finishing them by 3rd. So this whole schedule is there, and then they will be on our website as well as Global Genes US website. Really grateful to you. Or आप लोग कल I will request everyone to join us. Yeah, tomorrow morning we have a very interesting session of prohibitive cost, how to deal with challenge and medical insurance. A talk which we are requesting Shamika Ravi to deliver on this aspect. It will be very good, followed by a panel on parent support group tomorrow. Both of them will be very happy if you can join, and they are anyway being live streamed, and they will be there in the YouTube for anybody who doesn't have time. Thank you so much. And Dr. Kakuli, closing housekeeping remarks. And
thank you very much. It was really very, very informative for all the parents, all the patients, all the caregivers. I think we will cover up many of the interesting topics which Dr. Shefali has already commented on, that we'll have the financial issues covered in later half, which is a major concern for the parents and the patients. Thank you all. Thanks.
I'm pitching back one thing. Just reminding one thing. On Saturday, we have role of pharma industries, in which we are having representatives from Novartis, we are having from Sarepta, from PTC, and trying to get from Biogen. And so we'll be having, and Roche. And then we are having role of print media and electronic and social media for public awareness. Then on Monday, we are having role of NGOs for SMA, Indian NGOs and global. And the second part will be the NGOs of SMA separately and DMD. Then on Wednesday, we have scenario around the world. So we have people from across the globe talking about this. Then we have a very important thing, crowdfunding, hope versus hype, again on Wednesday. Then on Thursday, we have self-advocates and parent advocates. And then the financial solutions by the Humanitarian Access Program. And then on Saturday, we have financial solutions, employees beneficiary schemes. And lastly, parental counseling and coping strategies. We have to bring them a support from the beginning. So I hope that the webinars which we have planned out, and we thought from our heart how we will approach patients from all aspects, starting from approach to clinical diagnosis, therapeutics. I hope we make any difference. And together, I think हम सब साथ हैं, तो कोई भी मंजिल दूर नहीं है. पर एक बार बोलना है, hope is something, but hope से हम cannot bypass the scientific evidence. ट्रीटमेंट के लिए साइंटिफिक एविडेंस चाहिए. इसमें दिल से ही नहीं जाएंगे, सिर्फ होप से ही नहीं जाएंगे. हमें थोड़ा दिमाग लगा के साइंटिफिक एविडेंस के साथ करना है, क्योंकि हर चीज में साइड इफेक्ट और प्रॉब्लम्स भी हो सकते हैं, है ना. Thank you so much.
We cannot jump the steps. Yeah,
absolutely. Yes, Dr.
Otherwise, we'll stumble down.
Thank you, Dr. Shefali. As Dr. Shefali was pointing out, we will have major pharma industries who would be joining, and definitely, as Dr. Geeta was also saying, what is the new research we are going into, what are the kind of drug discoveries we are having for these kind of rare diseases would be covered on. Stay with us for all the other webinars. I would request you to be there, have discussions on. Share and care is the most important thing which we are looking forward for all the rare diseases. With that, we'll end this session.
Dr. Charan, कुछ बोलना चाहें?
Dr. Charan.
Thank you very much.
Thank you.
Bye.
Thanks. Bye-bye.
Thanks a lot.